Cavernous Sinus.
So let's go. I'm gonna say, introduce and tell the audience that every first Friday of the month it's gonna be peripheral nerves. Every second Friday of the month is gonna be skull base, and you are in charge of a skull base. And every last Friday of the month is gonna be brains anatomy. Yeah, somebody is invading.
What's
Yeah,
What's going
sometimes
on?
sometimes they have people invading somebody else's meeting.
No, sir,
Imad
that was
has,
coming from no, that was coming from Dr. Kentaro's mic.
oh, is that
Yeah.
Japanese music? Okay. So I'll give a general introduction and then Sebastian can introduce the team, the dream team. Is that okay? Agreed?
Yes.
Okay, wonderful. Feedback, yes. Wonderful. Mm-hmm.
JP, how are you?
Where's JP?
Hello.
Oh, JP.
Hey, Wayne.
Hey, how are
Hey,
you? Good
Paulo.
to see you.
Good to see you. Well, I'm just trying to fix my AirPod thing because I it's not working right now, but I hear you well from here. Good to see you all.
Uh-huh. Do you know everybody of the team?
Uh, I know Paolo very well. I know Sebastien,
Uh-huh.
Dr. Zhu. We worked together recently, I think, in a conference. Uh, and Dr. Watanabe, I know the name Dr. Watanabe, but I don't think we met before. Very nice to meet you.
Yeah, wonderful opportunity to meet each other.
How
Very
are you
nice.
doing, Wayne? Good to see you.
I'm good. I'm okay. Yes. It's
Good.
not so good time for Kentaro because it's 1 a.m. in Japan.
Mm.
But for all the rest, I think it's okay for you. Maybe Sanford is not so good either. It's almost midnight in Taiwan. For Paolo, it's close to France. It's okay in Italy.
Yeah, it's the same.
Yeah, and in Paris, it's around 6 p.m. It's a good time. Only for Kentaro and Sanford. So please stay awake. Sorry, just kidding.
But I'm sure that Kentaro prefer Paris time than Japan time. I'm sure that he
Oh,
likes.
sure.
I'm sure he likes a lot.
Paris is a wonderful place, wonderful city to visit. And he stayed 3 years. Lucky dude.
I stayed 3 years in Sebastian.
Mm-hmm. Wonderful. So I think Imad, I think everything's working. You want to test, Sebastian, you want to test your presentation? Well, who wants to test presentation? Is to share screen, this kind of things? Oh, Sebastian's having problem. I cannot open my microphone.
He rejoined, I guess. He can do it now.
Ah, perfect. Perfect. Thank you, Imad.
So maybe Sebastian, you can test your presentation to see if there's
Okay.
any problem.
Okay. So
I can see your screen.
is that fine?
Yes, Cavernous Sinus, the jewel box. Yes,
It's okay?
yes.
Perfect.
And the second, who is the second? You want to test your slides?
Second is Kentaro.
Kentaro,
Joao, how are you?
Hi, Sebastien. How are you doing? Ça va
I'm
bien?
fine. Ça va bien?
That's all my Spanish. Don't push it. My French, all my French. I'm sorry.
I can see Kentaro's slide. That's a video. It's wonderful. And the third one is
I
The
think it's
third
me.
is Joao. Yeah, it's Joao.
JP.
Yeah,
JP,
let me open it here.
share your screen. Yeah, let's see.
Okay. Okay, can you see it well?
Yes, Cavernous Sinus surgical anatomy and technical nuances.
Okay.
Wonderful. All right. Who is the fourth?
Paolo?
Paulo?
Paulo, I think you're muted.
Okay.
I can see you, I can hear you.
Yes. Can you see now?
Yes, journal neurosurgery, a surgical approach to the cavernous portion of the carotid artery. You're wonderful.
Okay.
Wonderful. Who else? Sanford? Parkinson. Winslow. Yes, your presentation is perfect.
Yes, it's working, but I want to stop it. But how can you? Okay, done.
Okay. Maybe Sanford?
Okay. You see my screen now?
No, I can see you.
Hmm?
Not screen. I can see you.
Not screen.
No.
Sebastien saw some nice photos of the course in Rwanda.
Yeah, it was beautiful.
Yeah, I mean, I was talking with Claire. She was super happy, super excited. That was very nice.
It was really, really nice.
Wanda?
In Kigali, yes, we have a course in Kigali, Rwanda. We did the first with Claire Karekesi a few weeks ago, in fact. And yes, it was really nice. A lot of participants coming from all over Africa. Yeah, it was nice. Really, really nice. Really enjoyed it.
I don't know why I can share my screen.
Well, keep working. I'm glad that you're not the first speaker.
So how to
share screen?
Sanford, I think you may have to go to the parameters, no, of go maybe on parameters of Zoom, and there is something about sharing screen, and maybe something here you have to activate.
Yes, I just clicked on the share screen, the icon, and it shows.
It happens to me recently, but I don't remember what was the solution. But I had the same thing recently. Imad, you have no idea to help?
Until I know what error he's getting, I won't be able to help. Maybe if you take me on WhatsApp, I can help.
Can you? Yeah. Sanford, you have WhatsApp number of Imad?
I have it. I'll send it to him if it
Okay.
doesn't have it.
Why I cannot share my screen? Strange.
I just sent Imad WhatsApp to you.
What's up?
Yes, that's his phone number. I just sent it to you. But anyway, it's only 2 minutes left, maybe.
So I just add Imad and how to fix the problem.
Mm-hmm.
Should I log out and log in again?
Maybe.
Yes, sir, you can try that.
Yeah. Now it's time.
Okay, I log out and then log in.
Ah. Atul is here. That's great.
Wonderful. Can we shall we start? Imad? Imad, it's time. Can we get started?
Yes, sir, we can start.
Can I start? Is that okay to introduce you guys? Hello, everyone. Good morning, good afternoon, good evening. Depends on where you are right now. We are live now. This is the beginning of the week 2 of each month of the huge project of World Federation of Neurological Societies, the Rhoton Anatomy Day. So every first Friday of the month, it's going to be about peripheral nerves. And Dr. Mariano Sokolovsky from Argentina, he's in charge of this. And the second Friday of each month, which is today, it's the Rhoton Anatomy Day is about the skull base. And the person in charge is the world famous Professor Sebastien Froelich from France. And for every last Friday of the month, it's going to be brains anatomy. And the person in charge is Professor Carolina Martins from Brazil. So, so here is Professor Sebastian Froelich, and maybe you can introduce our dream team to the audience. And I also want to thank you and thank all the members of our dream team, not only for skull base, not only for brain anatomy, but also for the peripheral nerves, for agreeing, for donating your time to help in this huge educational project. I thank you so much from the bottom of my heart. Thank you.
Thank you very much. Thank you very much. We thank you because you have been at the origin of this. So thank you so much for this opportunity. I have to say I am quite happy that you asked me for this. It's a great opportunity to share a passion for skull base, but even more than this for skull base anatomy, because it's definitely at the origin of everything. And so we wanted to start with the most famous region in the skull base for skull base surgeon. It's the one we all started with, trying to understand it as much as possible. And I thought to bring stars in the cavernous sinus on people that definitely share the same interest than me and all of us. So we have Kentaro Watanbe. Kentaro is an amazing skull base surgeon. And I'm not using amazing because I have to. I use it because he is an amazing skull base surgeon and vascular surgeon. I had the pleasure to work with him here in Paris, and I have to say he's extremely impressive. He has a passion for this tiny anatomy of the cavernous sinus, looking at the most tiny vessel possible to explore, as Japanese are. And he will do a fantastic lecture, I'm sure. We have Joao Almeida. He's a star also in skull base surgery. He's a star in neuroanatomy and teaching neuroanatomy. He's doing a lot for this in webinar, but he has also now a beautiful course. And it's a privilege to have him. I'm sure he will show some beautiful slides. We have Paolo Di Russo. Paolo is working in Pozzilli. It looks like a small town, but it's a beautiful center, and he's doing skull base surgery here. He's a fantastic skull base surgeon also. And I believe we share the same passion also for lab, for digging in the skull base and trying to understand more. We have Linda B. Linda, we all know Linda. She's coming from a prestigious institution, fantastic skull base surgeon, but also doing some amazing research, which is not so easy to do both, but she definitely can do it, and she's doing it. She will be a little bit late today, I believe, so she will speak last. We have Sanford H.A. Su, who is from Taiwan, Taipei, incredible skull base surgeon. He's doing things that we used to do with open approach, big approach. He's doing it now with very small craniotomy. So he has a lot to teach, and he's definitely at the front line of this type of surgery. And finally, we have Luigi Moro. Luigi is a research fellow in Paolo's lab. I had the pleasure to meet him recently in Pozzilli, and he's doing some great work in the lab about cavernous sinus, and especially about the sixth nerve. He is doing beautiful dissection to try to understand more about the trajectory of the sixth nerve. Endoscopic transcranial, it's one of the most difficult nerves to preserve when we do petroclival or endoscopic endonasal approach. And it will be a rule to include some of the young research fellows in our webinar to share some data about skull base anatomy. So if it's okay for you, I will start with the first lectures. I wanted to discuss a bit first before, hold on a second, before going deep into the subject, I wanted first to talk about what's before microanatomy, which is embryology and histology. And I wanted to say a few words about it because I started looking at the cavernous sinus from this point of view because of two persons. The first is Jeff Keller from the University of Cincinnati. I had the privilege to work with him for 2 years. For 2 years, he's my mentor in neuroanatomy, but also in skull-base surgery. And the second person is Pierre Kerli. He was also my mentor in Strasbourg, an amazing surgeon. Unfortunately, he passed away very young, but he was a genius, definitely a genius, looking at things with a different perspective, different eyes, different mind, genius mind. And he did a lot of research on the embryology of the cavernous sinus, histology of the cavernous sinus, comparative anatomy, which helped me to understand a lot about it. So this is my first slides showing you images coming from textbook about the cavernous sinus. There is many representation of the cavernous sinus. There is a huge amount of publication trying to understand the anatomy of the cavernous sinus. Some textbook shows the cavernous sinus as a big venous lake with the cranial nerve floating into the cavernous sinus. And in fact, it was the first representations of the cavernous sinus. And then some more anatomists tried to understand more about it. And it came progressively to this conception of an interperiostodural space. And this is definitely what it is. The cavernous sinus is not a venous lake crossed by cranial nerve, because there is not such a thing of a venous lake with cranial nerve floating into it. The cavernous sinus is an enlargement of a space between the periostom that is covering the bone and the dura propria. Inside this space, there is a carotid artery, there is venous channel, which are not veins because there is no muscular layers around the vein. So it's really a sinus and not a vein. It's endothelium, basal membrane, and this is surrounding by connective tissue. There is also cranial nerve. There is arachnoid sheath around the cranial nerve. There is fat also. So it's very important to keep in mind that the cavernous sinus is located between periostom, between dura. Everywhere there is dura, there is periostom. The dura is made of two layers, dural layer and periostal layer. So the cavernous sinus is just an enlargement of this space. Thanks to Parkinson, who describes the Parkinson triangle, but he also describes this extradural neural axis compartment. I advise you to read this article, which says that, in fact, there is a continuity of this interperiostodural space from the sacrum to the orbit. This is the same space that sometimes enlarges, sometimes reduces, and enlarges again. And at the level of the orbit, there is dura surrounding the optic nerve sheath. There is muscle, fat, nerve into the orbit. And you have the periostal layer, which is the periorbita. So the orbit is an enlargement of this interperiostodural space, part of the extradural neural axis compartment. About embryology, very nice and interesting to look at the embryology of the cavernous sinus. I advise you to read those articles from my mentor, Pierre Kerli. Not so easy to find, but extremely interesting to read. In fact, the cavernous sinus is coming quite rapidly in the development of the embryo. At the 4-5 weeks, there is a network of capillary around the brain. Those networks drain into 3 stems: anterior stem, mid stem, and posterior stem. And all of them drain into the primary head sinus. This is how it looks at about 4 or 5 weeks. And this connection between the anterior stem and the posterior stem, who runs medial to the trigeminal ganglion, is in fact the primary cavernous sinus. This comes from Paget. Paget, she wrote fantastic atlas about the development of veins. It's a little bit tough to read, definitely. It takes time. You need to be dedicated to it. But it's a fantastic material to understand the venous anatomy of the brain. So here is a more detailed picture showing you the stems, anterior stem, middle stem, posterior stem draining into the primary head sinus. And next, this anterior stem here is also fed by the primary maxillary artery. The primary maxillary vein, will lead to the ophthalmic veins, and the middle stem will probably disappear, progressively disappear, and the middle capillary and the posterior capillary will join behind the otic capsule and will form the transverse sinus as well as the sigmoid sinus. I will not go into the details, but this is just to give you the advice to really look at this embryology. It's absolutely fascinating to go to see the step-by-step formations of those veins. Here you see at 7 weeks, you see at 9 weeks, you have here this middle stem here in front of the otic capsule. Behind you have this middle capillary plexuses and posterior capillary plexuses who join behind the otic capsule. And you see that the next step is that this junction become the transverse sinus and the middle stem disappear. And you start to see here transverse sinus, sigmoid sinus, jugular vein. And here is the cavernous sinus with the main outflow, which is the inferior petrosal sinus. So this is a cast from Batson. Batson was an anatomist, and he gave this cast to Jeff Keller. And this cast is beautiful because it shows you this network of venous channels of the cavernous sinus. Both cavernous sinus connect each other with same channels, tiny channels anterior to the pituitary gland, behind the pituitary gland and the sella. And you see here the main outflow of the cavernous sinus, which is the inferior petrosal sinus draining into the jugular bulb. That's the main outflow of the cavernous sinus. Sometimes the middle cerebral vein do not drain in the cavernous sinus, but drain into a lateral cavernous sinus, which is another venous lake lateral to the cavernous sinus, which is only a step to drain directly into sigmoid sinus, transverse sinus. That's here a coronal view drawing of it, showing you the cavernous sinus here on this lateral cavernous sinus lake, which can drain the middle cerebral vein, superficial and deep cerebral vein. That's a coronal section of embryos. Why it is interesting? Because here you see the trigeminal ganglion. It's about 7 weeks. And you see here this prootic sinus, which is the primary cavernous sinus. It's not a plexuses, it's a single big venous channel medial to the trigeminal ganglion. All this is surrounded by mesenchymal tissue. Progressively develops, the brain push the meningeal layers progressively and gives this shape to the cavernous sinus with a lateral wall, superior wall, with this posterior free edge of the tentorium, as you can see here. Here in this coronal slides, that's 14 weeks, you have the clinoid process, this trigeminal ganglion, You have the third nerve here below the clinoid, and you have this carotid artery, which is quite vertical at the beginning. And with the development of the embryon, it starts to have this shape of posterior ascending horizontal segment and anterior ascending segment. This is histos of Meckel's cave. What's important to understand is that the cranial nerve developed before the meninges. So when we say that an arachnoid pocket is pushing the dura following the nerve, this is not true. There is no such a thing pushing the dura like a finger in a glove. Everything developed progressively, but the cranial nerve developed first, and around the cranial nerve developed this arachnoid and the meninges. You can see here, there is this beautiful article also from my mentor, Pierre Kerley, about the sheath of the arachnoid around the cranial nerve into the cavernous sinus. He looked at embryos, fetuses, newborn, with those beautiful histological slices. Here you have the third nerve, and you see this arachnoid sheath here, this very thin layer of arachnoid following the third nerve. So what about the lateral wall of the cavernous sinus? We all know that the lateral wall of the cavernous sinus is made of temporal dura covering the cavernous sinus. It's like a drape that is covering the skull base. This is without this drape, and this is with this drape. You have this layer of dura propria covering the cavernous sinus. It's interesting to have this concept in mind, because if you take the drape out like this, you can expose the inside of the cavernous sinus. That's the lateral view of the cavernous sinus, with the drape covering the cavernous sinus, with the dura propria covering the cavernous sinus, and that's how it looks when we peel this drape from the inside of the cavernous sinus, exposing the cranial nerve. This is an important concept in skull base surgery, especially for meningioma surgery, because if you peel this drape in case of a cavernous sinus meningioma, you separate the part of the tumor which is inside the cavernous sinus, and that most likely you cannot take out because it infiltrates the cranial nerve, from the intradural part of the meningioma that you can definitely take out. The principle of this peeling, we know it. This is here a cartoon showing you a cranial nerve. It could be V1, it could be V2, it can be V3, crossing a foramina. In red, it's a periostal layer covering the bone. In green, that's the dura propria, this drape covering the skull base. We come from lateral, we elevate the dura from the bone, dura propria, periostal layer together. And at some point, we reach the point where we get to the foramina, and we are facing this periostal bridge that connects the endocranial surface to the exocranial surface, because there is a continuity of the periostal layer. We incise this periostal layer, and we can keep going, peeling the dura from the nerve. We can do that starting at the anterior clinoid process, cutting the orbitotemporal periostal fold. We can do that starting at V3, and that's the initial step of an anterior petrosal approach. That's an histological slide showing you that this peeling of the dura is not completely safe, because when we peel the dura from the cavernous sinus, we expose the cranial nerve. And the one that is most exposed is the trigeminal nerve and the fascicles of the trigeminal nerve. And if you are not careful, you can injure those very tiny fascicles of the trigeminal nerve. So when you do that, no coagulation, because if you coagulate, you will coagulate those fascicles, which are sometimes extremely tiny. On this histological slice, you see on the right side, the lateral wall has not been peeled, But here, there was a clinoidectomy and a peeling of the lateral wall. And you see those tiny bundles here of the trigeminal nerve that were lifted away because of the peeling. So you can easily injure those tiny fascicles of the trigeminal nerve. Medial wall of the cavernous sinus. Is there a medial wall of the cavernous sinus? This is a big debate. There is people saying there is a medial wall. Some people saying there is no medial wall. I am from the second category. There is no medial wall of the cavernous sinus. And I explain you why. If you look at embryos, you understand that in embryos and fetuses, there is a continuity between the pituitary fossa and the cavernous sinus. It's the same region. There is no separation. Everything is into mesenchymal tissue. The pituitary gland, the carotid, the cranial nerve, all this is into mesenchymal tissue. And you can see it here at the early stage of the formation of the pituitary gland here. You have it here on the sphenoid body. You have the trigeminal ganglion, and you have this layer, which is the origin of the dura and arachnoid. And you see that it's covering here the pituitary gland, but there is no separation between the sella and the cavernous sinus. This is a little bit later, exactly the same. You see here the pituitary gland, and you see here the venous channel of the cavernous sinus. What's in between? It's not dura, it's just mesenchymal tissue. And if we go a little bit further in these fetuses, this is a little bit later. You see here in these fetuses the pituitary gland. You see here the venous channel of the cavernous sinus. You see the third nerve with the arachnoid cistern around it. And you see that between the venous channel and the pituitary gland, there is no dural layer. Dural layer is here on the lateral wall, but not here in the medial wall. The medial wall is just a thickening of connective tissue, but it's not dura mater per se, because we can only talk about dura mater when there is arachnoid in front of it. This is another histological slice showing you exactly the same pituitary gland on the venous channel of the cavernous sinus. There is no wall in between both. And this is exactly why pituitary adenoma infiltrate very easily, extend very easily in the posterior aspect of the cavernous sinus. This is an adult section. I had the chance, good fortune, to do a dissection in a cadaveric specimen when I was in Cincinnati, and I found out that there was a pituitary adenoma. I stopped, and we did a block to study the infiltration. And we saw exactly the same in an adult. You see here a cavernous sinus. This is dura mater above, superior wall. This is the tip of the clinoid. This is a normal pituitary gland. And you see that between normal pituitary gland and cavernous sinus, this is carotid. There is no wall. There is no dura mater. It's exactly the same here. You have the pituitary adenoma, carotid artery. This is dura mater here. This is dura mater on the side, but there is no dura mater between both. I think I will stop here because I am a little bit behind schedule. Wanted to tell you about the superior wall, but I'm sure Joao will say more about it. Wanted to tell you about the carotid artery, but the carotid artery is the most well-known structure in the cavernous sinus. Different way to look at it, but the anatomy do not change. The difficulty is to make the correspondence between what we see when we do a transcranial approach and what we see when we do an endoscopic endonasal approach. Few more histos. This one showing you the clinoidal segment of the carotid artery. Here, a clinoid process. And you see here the third nerve and fourth frontal branch and below the sixth nerve here. Progressively fourth and frontal branch will run over the third nerve to get into the orbit. You can see here that there is a distal dural ring made of dura mater. There is no real proximal dural ring. The proximal dural ring is in fact just the venous wall on the endothelium on the basal membrane with connective tissue, but it's not dura mater, which is definitely present at the level of the distal dural ring, and that's where it can be hardly separated from the adventitia of the vessel. The carotid artery is highly variable from one person to another, especially when you look at it with endoscopic endonasal approach. The shape is completely different, and this is important to take care of when you do an endoscopic endonasal approach. I will stop here and I will continue with histology when we will discuss about the superior orbital fissure. Thank you very much. So we will discuss a bit later if we have questions. And I propose that we keep going right now with the second lecture. Kentaro talking about arteries, branches of the internal carotid artery inside the cavernous sinus. Thank you, Kentaro.
Okay. Thank you, Sebastien. And then thank you everybody to giving such a good opportunity. So I'm very happy to be here and then present about the broad supply of the cranial nerves in the cavernous sinus. So, okay. So now it's in Japan. It's 1 o'clock. So I'll be sleepy, but I will try to do my best. Okay. So as at the first, we're talking about the venous system of the cavernous sinus. So Sebastien, he already explained about the anatomy of the venous channel of the cavernous sinus. So as I will try to just a simple way. So as a cavernous sinus located just center of the venous system, and then there's a three vein is to flow into the cavernous sinus, which is superior ophthalmic vein and inferior ophthalmic vein and sphenoparietal sinus. And then the flow out is as Sebastien he said is the main flow out is inferior petrosal sinus. Or there's also another flow out route is pterygoid plexus, and then the foramen ovale rotundum, vein of foramen ovale and rotundum, and then sometimes the superior petrosal sinus is a flow out or some. It's a variable. And also the vaginal plexus, also the flow out route. So this Y3D way, the superorbital vein, inferiorbital vein, and the sphenoparietal sinus going to the cavernous sinus and flow out to the inferior petrosal sinus and the vaginal plexus, so like that. So when I see that the lateral wall of the cavernous sinus, you can see that this anatomy, also oculomotor, the trochlear nerve, and the V1, V2, V3, the trigeminal nerve, and GSPN is around here. So when you see the inside of the cavernous sinus, there's the small arteries. This is the meningohypogea trunk. And also that we can see the small arteries around the V1, V2, V3. These arteries we will explain. I will explain about it. And also here, there's a small arteries coming from maybe from here to the trochlear nerve or oculomotor nerve. So when I see this is a schematic view of the cavernous sinus. Here, this venous system from the like this, and this triangle. This is a Parkinson triangle. This is which is a biggest triangle in the cavernous sinus. Is a sphenoparietal sinus. Is the venous vein is coming to the Parkinson triangle to the cavernous sinus. So it's already shown it. So we can see the periosteum and the dura layers here, and you can see the small venous rake, venous structure between the nerve and the carotid artery, and the periosteum and the dura mater is here. So there's no duras around the carotid artery, but there's a neural cyst around the cavernous sinus, neural cyst around the nerves, like that. So next is a broad supply of the cranial nerves of the cavernous sinus. So related to arteries, so we know that inferior lateral trunk, meningohypophyseal trunk, and the middle meningeal artery, and the accessory meningeal artery, and internal maxillary arteries, ophthalmic artery. These arteries is supplied to the cavernous sinus nerves. So at first, we can focus on the inferior lateral trunk or the meningohypophyseal trunk. So when you see there's the inside of in the cavernous sinus Parkinson triangle, you can see the small arteries. This is the meningohypophyseal trunk. And then when you see the inside of cavernous sinus, you can see the carotid arteries coming from here to the neck, like that. And then in the medial side, there's a meningohypophyseal trunk. So lateral side is we can see that inferior lateral trunk like this. And then, usually we cannot see the inferior lateral trunk from the lateral wall of the cavernous sinus. So we have to see that the medial side of the cavernous sinus to see the inferior lateral trunk. So this is the endoscopic view. This is a carotid artery. This is the V2 and the V3, and this is the sixth nerve. And as the sympathetic nerve is here, this is the median nerve. So when you see look these areas, you can see that the small artery. This is the meningohypophyseal trunk, and this lateral one is a inferior lateral trunk. Very tiny artery, but it's a very important artery for the cavernous sinus. And also this anastomosis of the these arteries is very important. So here, this inferior lateral trunk is coming from the lateral wall of the cavernous sinus, the lateral wall of the carotid artery. So there's a small branches is a superorbital fissure branch, and the foramen rotundum branch and the foramen ovale branches. And then anastomosis with a first superior ophthalmic, no, SOF branch is anastomosis is recurrent meningeal arteries coming, and it's one of the anterior branch of the middle meningeal artery. And as foramen ovale, foramen rotundum branches, anastomosis with the maxillary arteries. And the foramen ovale branch is anastomosis is the accessory meningeal artery. And also, when you see the meningohypophyseal trunk, there's three branches. It is inferior hypophyseal artery, and the marginal clival artery, or the marginal tentorial artery. These artery also the anastomosis. The clival artery is anastomosis, the contralateral side of the clival artery. And then the lateral clival artery is anastomosis of the ascending pharyngeal artery. And also the tentorial arteries, sometimes anastomosis with the inferior lateral trunk. This anatomical network is very important for that. So when you see here, these meningohypophyseal trunk arteries, and also when you see the lateral side, so you can see the small arteries. This is the one of the branch of the inferior lateral trunk. So next artery is middle meningeal artery and accessory meningeal artery and internal maxillary artery. So when you see the middle fossa of and around the trigeminal nerve, so we can see the middle meningeal artery. So you know the very famous artery of the middle fossa. There's a internal maxillary artery has a middle meningeal arteries going to the foramen spinosum, and also the small branches, accessory meningeal arteries going to the foramen ovale. So these arteries also to go to the cavernous sinus. So you can see here this artery is a meningohypophyseal trunk, and then this is oculomotor auricular nerve, and this nerve, this artery is going to the clivus and then tentorium. And also when you see that the peripheral areas, as you can see the small arteries is coming from, this is one of the branch of the inferior lateral trunk. And the inferior lateral trunk, the branches are anastomosis with this V2. There's from this maxillary artery has the small artery from to the V2, and then the inferior lateral trunk, the foramen Rhoton branch is anastomosis with this internal maxillary arteries branches. And when you see that, see here the great. And then here we can see, if you see the V3 areas, so you can see the small branches from the inferior lateral trunk and also the ascending accessory meningeal arteries, the anastomosis is around here. So next artery is ophthalmic artery. So it's not, usually it's ophthalmic artery is not related to the cavernous sinus artery, but it's when you see that this anatomy, so you can know that the ophthalmic artery also related to the cavernous sinus. You see here this ophthalmic artery where there's some branches going to the supraorbital fissures. Here, this is small arteries. And then you can see here, this artery is ophthalmic artery has several branches to go to the muscles and nerves, and there's like a oculomotor and abducens nerve and ciliary ganglion. There's all the orbital nerves has was supplied from the ophthalmic arteries. So, but if you see the inside of the supraorbital fissure, you can see the small branches coming from the ophthalmic artery. And also this artery is supply the nerve to the oculomotor nerve. So it's so I will show that another movies. So you can see this ophthalmic artery is a very important artery also. So as the next one, the nerve, the cavernous is these nerves is related in the cavernous sinus, oculomotor, trochlear, trigeminal, abducens, and the facial nerve. So first, the oculomotor nerve. So you can so the oculomotor nerve is coming from the ventral side of the midbrain, and then you can see here there's a oculomotor nerve, and there's a three segment: cisternar segment, and the cavernous sinus segment, and orbital segment. And then the cisternar segment oculomotor nerve is coming is a supply blood supply from the PCA. And then cavernous sinus segment is blood supply from the ILT, or meaning hypoglossal trunk. And then ophthalmic orbital segment but is supplied from the branch of the ophthalmic arteries, like that. So you can see that here this small arteries coming from the posterior PCA, and this oculomotor nerve is the supply blood supply from the PCA. This is the thalamo-perforating arteries. And then here you can see the thalamo-perforating arteries. Here there's a PCA, and the small arteries is going to the oculomotor nerve. And the oculomotor nerve is going to the tentorium and the oculomotor foramen, passing the oculomotor foramen and go to the cavernous sinus. But after the passing through the tentorium, there's another arterial supply. So there's a cavernous sinus segment. So there's a cavernous sinus segment oculomotor nerve is there's a blood supply from the inferior lateral trunk or meaning hypoglossal trunk. So you can see this, and this is the oculomotor nerve, and then here there's a small arteries coming from the meaning hypophyseal trunk. And so the anterior part is anterior part of the oculomotor foramen, oculomotor nerve is supplies from the inferior lateral trunk. And also the inside of the orbit, the orbital segment is artery blood supply from the here. This is the oculomotor nerve. Oculomotor nerve is separated, divided two branches, superior branch or the and inferior branches. There's a small arteries. Here is coming from the ophthalmic arteries. Here, this is a small artery is going to that. And then when you open the supraorbital fissure, here, this is the artery is coming the ophthalmic arteries like this here. So it's for the carotid artery has the ophthalmic artery, and then one branch is coming from the orbital segment and coming back to the oculomotor nerves like that. That is very interesting. But I cannot find the name of these arteries. I think it's one of the here. This is the supraorbital fissure, saying it's more arteries coming from the ophthalmic artery and they go to the outside. So it's means there's deep recurrent ophthalmic artery. Maybe this one is one of the branch of the oculomotor foramen. I cannot find this right name also. Okay, if you somebody knows it, can you tell me that? So, and then as a second, next one is a torcular nerve. Torcular nerve is coming from the dorsal of the pons. And then you can see that here is a cisternar segment, dural sleeve segment, cavernous segment, and orbital segment. And the cisternar segment is SCA, the dural sleeve segment, meaning hypogea trunk, cavernous segment is the IRT, and ophthalmic branch is the ophthalmic artery. So we can see that here is a fourth nerve is coming from the supply from the SCA, plus the small arteries coming from the SCA and going up. Here you can see that here's small artery from the SCA to the fourth nerve. And then the cavernous segment is around here. Is around here is the meaning hypogea trunk that supplies the fourth nerves. And then the anterior part is from the meaning hypogea trunk. But dural sleeve segment here, this is a little bit different. It's here, the dural sleeve segment is there's the supply from the meningohypophyseal trunk is a small artery that from the tentrium. And then so when you see there's a orbital segment here, this is a fourth nerve. The fourth nerve is around is outside of the orbital segment. So it's and it's not the blood have the blood supply from the directly from the ophthalmic vein, ophthalmic artery. I think it says this nerve is the vascularization from the periosteal dural layers was a supply to this torcular nerve like this. There's no big arteries around here. So I think it's a master branch is ophthalmic artery. There's no right the name of these arteries. I cannot find it also this. And so next one is a trigeminal nerve. So trigeminal nerve has it's a little bit big nerve. So there's a lot of blood supplies. So we can see that here, this trigeminal nerve is vascularization from the SCA and basilar artery and anterior inferior cerebral arteries. So here, this segment, you can see, make a segmentation. Those are like a cisternar segment or a cavernous sinus segment and extracranial segment. So this is a SCA, IRT, or the others like that. So when you see there's a trigeminal nerve has the blood supply from basilar artery and PCA and anterior inferior cerebral arteries like this. So from here, basilar arteries, blood flow and I curve and PCA, so like this. And the cavernous segment is a vascularization from the ILT and then meningohypogea trunk like this. And the ILT has the three branches, the V1, V2, V3, and then these arteries are anastomosis is a middle meningeal artery, also ascending accessory meningeal artery, and super so the palatine arteries, so it's a maxillary artery, and a recurrent meningeal artery, and ophthalmic arteries like that. So this is a small arteries, as all arteries are anastomosis, which are the carotid artery and the external carotid arteries like. So this is almost the same movie. So it's I will skip. So extracranial segment is we have to think about the arteries from the carotid, the external carotid arteries branches of them. So abducens nerve. So this is the last nerves. And the abducens nerve is coming from the lower of the pons, and you can see the segmentation, the posterior fossa segment, the cisternar segment, and the dural segment, and the cavernous segment, and the orbital segment. So, and you can see there's a carotid abducens nerve has a vascularization from the ICA and the vaginal artery, and these two arteries that supplies the cisternar segment. And then also dural sleeve segment is a little bit different. So dural sleeve, you can see that this is the dural sleeve of the abducens nerve. There's more arteries. This is the clival artery from the meningohypophyseal trunk. These arteries artery and sixth nerve is run together from the Dorello's canals like that. And then as you can see, this is the cavernous sinus segment. You can see that after the passing the Dorello canal, the sixth nerve is coming up and round with the carotid artery. So this segment is blood supply from the carotid artery directly, so like that. So here, this sixth nerve has a small branch from the inferior lateral trunk, and also the small branch from the carotid arteries directly like this. So here this so last segment is the orbital segment of the sixth nerve. Abducens nerve is around so just below the nasociliary nerve. Here, the abducens nerve from below the trigeminal nerve, and then they go to the supraorbital fissure, and then go to the intraorbital segment here, and then go to the lateral rectus muscle. There's a small arteries around it, but this segment is blood supply from the muscle branch of the ophthalmic artery. So this is vascularization of the cranial nerves of the intercavernous sinus. So an important aspect of the vascular anatomy in the cavernous sinus is the anastomosis of the vessels. As knowing the vascular innervation of the nerves will enhance an understanding of the anatomy of the cavernous sinus. Thank you very much. I'll be too over, so I'm sorry that.
Thank you, Kentaro. It's absolutely amazing lecture on pieces of anatomy. Can you stop sharing your screen, Kentaro? Perfect. Yes, so absolutely amazing dissection. It's amazing to see how rich in vessels, except the cavernous sinus, except the carotid arteries, the cavernous sinus. In fact, it's a complex network of branches, tiny branches going to cranial nerve, and absolutely beautiful. So let's move to the next lecture, which is more of a surgical lecture, I guess, from Joao Almeida, talking about how the cavernous sinus looks when you look at it from a transcranial approach and from an endoscopic approach. Thank you, Joao.
My pleasure. Thanks for the invitation, Sebastien. Thanks, Dr. Wen, for the opportunity to participate in this program. So I'm going to be highlighting the next few minutes a little bit of what I consider to be some key concepts on the surgical anatomy on the cavernous sinus, both from above and below, and how we see that some of those key concepts can be applied in the surgical theater, in addition to the surgical laboratory. So I think you can see my slides okay?
Yes.
Okay, perfect. So I have no financial disclosures, but I like to always thank those, two giants that are not here with us anymore. Dr. Evandro de Oliveira, who was really, the source of inspiration for myself and many others to get into, to become passionate about surgical anatomy of the brain and the skull base. And also, my mentor for cavernous sinus surgery. And Dr. Fred Gentili from Toronto, that is my mentor for endoscopic skull-based surgery, that helped me many things in life, including surgery, but more importantly, in how to translate some of the concepts of surgical anatomy that we had from transcranial approaches into the endoscopic skull-based realm as well. And here, just some points that we think when we think about cavernous sinus and tumors in the cavernous sinus. We believe that there are three factors that are key: the surgeon-related factors, patient-related factors, and tumor-related factors that we must take into consideration. Today, we're going to be focusing on the anatomy of the cavernous sinus and how to use that and translate it into some surgical techniques to achieve effective surgery. But it's important to understand that you really need a team to achieve, in my point of view, success in the management of those patients. Usually, even a successful procedure, patients may still need support for rehabilitation. Patients may still need additional therapy, such as radiosurgery, proton therapy, carbon ion therapy, and so on and so forth, and endocrinological support. So not only a neurosurgical condition, but really a multidisciplinary condition. Patients are different, so you need to understand what is the clinical presentation, what are the previous treatments and expectations and quality of life. And finally, the tumor-related factors where pathology of the tumor, such as, pituitary adenomas are different from meningiomas, which are different from schwannomas, which are going to be different from chordomas and chondrosarcomas. Those factors must be taken into consideration. And finally, the anatomy of the tumor itself. So we're talking cavernous sinus, but it's quite well possible that the cavernous sinus is just one more compartment that tumor is going to be affecting in your patient. So, for example, pituitary adenomas will be arising from the midline, the sella, extending into the cavernous sinus and potentially so the middle fossa. Chondrosarcomas and chordomas, clivus or Petrus apex, respectively, and trigeminal schwannomas, the Gasserian ganglion towards the midline. So those would be some key factors that we're going to be reviewing and that I think we should all take into consideration when selecting treatment options here. Once again, from those giants, I always like to remember the lessons I learned from them that, passion is key for what we're going to be doing, but hard work and commitment are necessary to go hand in hand with the love for or profession or skills. Perfection is the goal, and the road to achieve that in our surgery is really microsurgical anatomy. And to have a chance to work in a dedicated skull-based lab such as the one that we have here, I find it to be key. I particularly find very difficult to progress into this realm without an ability to work in a surgical anatomy lab, and therefore I encourage everybody to look for opportunities to practice and almost as much as possible to get into that field. So when we look at it from above, as we have been discussed before, there is a classic way to get into the cavernous sinus, which is really going through the roof of the cavernous sinus. And then here we can divide the space in anterior splice or the clinoid segment covered by the anterior clinoid process. And that's really going to give us access to the clinoid segment of the carotid. In the posterior space, which is the oculomotor triangle, is the one that really will provide a door to get into the cavernous sinus from above by working around the cisternal segment of the oculomotor nerve. From a lateral wall perspective, to get into the cavernous sinus, you really have, as Dr. Parkinson's described, the corridor around trochlear nerve, so working above the trochlear nerve and below the trochlear nerve in the supra and infratrochlear triangles, while the anterior medial, so V1 and V2, and anterior lateral V2 and V3 triangles are triangles that will provide you access more so to the lateral recess of the cavernous sinus, and then if you follow V2 into the pterygopalatine fossa and V3 into the infratemporal fossa. So also important triangles, but much more so to manage the middle fossa. And nowadays, with endoscopic endonasal surgery, we also have the anterior corridors that provide us with an excellent access to explore the cavernous sinus, especially so for soft tumors such as pituitary adenomas, chordomas, and chondrosarcomas, but also an opportunity for trigeminal schwannomas, in our opinion, which basically are limited. You have access through anterior wall of the cavernous sinus, and you can also open and approach the superior and posterior compartments through a medial wall of the cavernous sinus. Therefore, I particularly like to divide that space in two basically big regions, one in front of the carotid that we're going to call anterior lateral, therefore the one that you see right here, and the posterior medial located just behind and in medial to the carotid. And that I like it like that because it helps me to think about how we're going to be attacking those tumors during surgery. Going a step by step in terms of surgical anatomy, surgical details that we must consider, in my point of view, there are three structures that are key here, which are the clinoid processes. So when we look from above, therefore, through transcranial approaches, the anterior clinoid process is a key structure that often needs to be removed so to provide adequate access to the cavernous sinus. Especially so, it must be removed if you're going to work in the roof of the cavernous sinus. And you can see here why. You can see that in this right side, the anterior clinoid process is intact. In the left side, it has been removed. And you can clearly see that it blocks your access to the most anterior part of the cavernous sinus roof. Therefore, it blocks the access to the clinoid segment of the carotid. The anterior clinoid process will be limited by 3 points of attachment, one with the sphenoid wing, following with the plano and lateral wall of the optic canal, and then a little point located just below the optic canal, which is the optic strut. And therefore, its removal requires drilling and thinning of those structures so that you can out-fracture and achieve a complete resection of the clinoid process. It is also important to remember that on its tip, you will have the attachments of the small clinoidal ligaments that will connect the dura of the clinoid with the tentorium and the petrous bone. A second structure that is key is the middle clinoid process. This one, as you're going to see in a second, will be more relevant to endoscopic endonasal approaches and then to the access of the clinoidal space through endoscopic approach. The posterior clinoid process here represented, it is a key structure both for endoscopic endonasal approaches and transcranial approaches. You can see here that the posterior clinoid process on both sides are communicating the midline with the dorsal sella, and therefore they work as a gate separating your access from transcranial or endoscopic, separating you, the surgeon, from the interpeduncular cistern located just behind that area. So when you look at this through an endoscopic endonasal perspective, the lateral optic carotid recess, which is this depression between the optic canal and the clinoid segment of the carotid, it is the one relevant point that you can see from below in regards to the anterior clinoid process. In practicality, I myself have never gone through the anterior clinoid process on an endoscopic endonasal approach, and I find that to be less relevant today. I mean, you can always use a transcranial approach as well, but the middle clinoid process is a little bit of a different piece. When prominent, this clinoid process blocks your access to the dorsal clinoidal space located just behind the clinoid segment of the carotid, and also blocks the visualization of the superior compartment of the cavernous sinus. Therefore, its removal can provide you access to this angle. In terms of dura, Dr. Froelich already described. I mean, and this is a key concept, as Dr. Froelich mentioned. The venous spaces in the base of the skull, including the cavernous sinus, are nothing but a separation between the meningeal, the periosteal layer and the bone, and the dura propria meningeal layer. So every time that separation happens, you're going to have a pocket of venous blood, in this case, the cavernous sinus. So here you can see the meningeal layer is intact here in this case. So this is like an intradural view after a pterional approach, for example. And then you can see here the posterior roof of the cavernous sinus with the third nerve and the anterior clinoid process in the lateral wall of the cavernous sinus. And if we mobilize that meningeal layer, we can expose and see the thin periosteal layer that covers the cavernous sinus. And that is the key point of the peeling, that therefore you can visualize the location of those nerves and then identify the safest place for entry. Once again, usually around the supratrochlear or infratrochlear triangle, so that you can approach lesions located inside the cavernous sinus when indicated. From endoscopic and nasal perspective, there is the big concept, and as Dr. Froelich was discussing, in terms of it is a medial wall or if it is a thickening of the mesenchymal layers. I particularly don't know that what is the most precise name, but what I can tell you is that you can identify when working through endoscopic perspective that indeed in the sala you can clearly see the two layers of dura. And here you can see I dissected the most superficial layer, the periosteal layer, and then you can identify the superior intercavernous sinus, inferior intercavernous sinus, anterior walls of the cavernous sinus on both sides. And you can see this meconal perforating branch running just in between those layers. And therefore, when you open the anterior wall of the cavernous sinus, you can identify the separation between the cavernous space, the ciliary space, and here in this case, you can clearly see this thickening of tissue that here I'm going to call medial wall of the cavernous sinus that will separate the cavernous sinus space from the ciliary space. And that is in consideration that this called anterior wall would be the continuation of the periosteal layer running just in contact with the bone of the skull base, while the meningeal layer would continue from diaphragma downwards as the medial wall of the cavernous sinus. In terms of transcranial approaches, the one favorite approach for us is really the pretemporal approach. And we say that because for cavernous sinus, we're looking down, and the OZ approach usually is interesting and needed when you're looking up towards the roof of the third ventricle. Therefore, in our point of view, not needed it. It's still, of course, doable, but not needed it. Clinoidectomy is key, and the peeling and the middle fossa are steps that we must all be comfortable with. When doing an anterior clinoidectomy, once again, the 3 points: removal of the sphenoid wing, drilling of the plenum attachment and lateral wall of the optic canal attachment, and then finally, the drilling towards the tip and below the optic canal, the optic strut, which will allow you then to out-fracture that anterior clinoid process and then identify the clinoid segment of the carotid, the connection then of the distal dural ring with the optic canal, and you can identify here the proximal dural ring and its extension with the so-called carotid oculomotor membrane between the carotid and the oculomotor nerve here identified. So here, before showing this specific case, I'm going to share this other specific video here, which is a simple video of a clinoidectomy, where you can see this is the left side. This is an extradural approach. I particularly like to do an extradural clinoidectomy. And you can identify here with a partial peeling of the middle fossa all the way to the tip of the clinoid. After that, you see the sphenoid wing had been drilled. You can drill first towards the lateral wall of the optic canal using a diamond board. This is a 3mm diamond board. And then you can see here the optic canal already exposed. After that's done and thinned out, you can just go ahead and go all the way to the, basically, to the optic strut, drill that area, and then you can out fracture. Remember to mobilize from down up, so away from the carotid, and then from medial to lateral all the way to optic canal. Once that's done, we're going to be able to identify the clinoid segment. You have venous blood that comes from the cavernous sinus and the clinoidal space. And then basically you can unroof the optic canal afterwards and go ahead to identify the clinoid basically segment itself. See optic canal, the dura is open. In this case, we did this for basically an optic sheet distal dural ring meningioma. Okay, so let's go back to that presentation here. So I'm gonna, in this case, was basically to demonstrate this is not a cavernous sinus meningioma. This is a sphenoid wing clinoidal meningioma, but the anatomy of the cavernous sinus is also key when working with this. So just to demonstrate from a transcranial perspective, in this case here, this was a case that I had with my chairman, Alfredo Quinones. It was in a pretemporal approach. So interfacial dissection here demonstrated harvesting of the pericranium, mobilization until the frontozygomatic suture, mobilization with preservation of a cuff in the temporalis muscle, and then after that, the craniotomy as per usual. Drilling of the sphenoid wing of the orbital roof, once again, anterior extradural anterior clinoidectomy. And then after that, what I did here was basically to unroof the posterior part of the orbit. You can see the opening of the optic canal and early identification of the tumor inside the optic canal, as this patient had a meningioma with a partial invasion. Once all that's done, you can clearly see there the tumor and the optic nerve. And after this component of the surgery was completed, it was really about exposing the tumor, mobilizing them to an M3 branches following the classic microvascular dissection, which is also key. By the way, I don't see any separation between skull base and vascular. I think we follow the same principles. And after that, tumor debulking, and finally separation in extradural fashion of the tumor. You can see here the final view with optic nerve, carotid, and I was very happy with this resection. Patient did well and had this MRI scan with improvement of the vision. So continuing with the line of dissection, we already completed the clinoidectomy. And now here we must rely on the identification of the oculomotor cistern. So in this case, I'm gonna start opening the roof, and you can see here the optic system was open, the oculomotor system was open, the dura propria was separated, and we can see now the basically the periosteal layers. And that gives us, once again, what we see inside the cavernous sinus. Then you can see distal dura ring, clinoid segment, proximal dura ring, and then the components of the cavernous sinus itself, including the horizontal segment of the carotid, posterior genu, vertical segment. And here you can see, once again, the meningohypophyseal trunk, as previously demonstrated, and the inferior lateral trunk. And you can see that between the supratrochlear and the infratrochlear triangles that you're really going to be working to identify and work around the cavernous sinus. If you use this in terms of step-by-step to deal with cavernous, with meningiomas lateral to the cavernous sinus or attached to the lateral wall, it is interesting to see that if you follow a specific step-by-step, you can remove those tumors by preserving the nerves. And the key is peeling the middle fossa, anterior clinoidectomy, a dissection all the way to the superior petrosal sinus. You can combine that with a Kawase drilling. The limit is the superior petrosal sinus, and then it's really opening the subtemporal dura, which will expose your tentorium, identifying the fourth nerve, and then you can basically transect the dura in between the nerves. And that is only possible, in my point of view, with a proper peeling, as previously discussed. That's what was done in this case. That was, as you see, this is a recurrent clinoid meningioma, but that now is coming from the posterior clinoid and attached to the tentorium. This patient was just in a pretemporal approach. And after that, you see through a subtemporal corridor, basically almost in an extradural fashion. I just opened the dura in the base. We could go ahead and mobilize this tumor. You can see the carotid. You can see some attachments of the tumor in the base. And I could get a pretty good corridor working above the tentorium, but you can see the third posterior communicating, but the tumor was attaching here inferior to all of this. So to proceed with that, we needed to identify the periosteal layer. And then what I'm doing here is I'm transecting the dura to identify and isolate the trochlear nerve and to be able to mobilize that forward. So just following the trochlear nerve, which can be seen here now in the interdural segment as previously demonstrated by Dr. Watanabe. And as we unroof that trochlear nerve, now I have trochlear nerve, I'm going to have the fifth nerve, and then I can work around all that. So I have third, fourth, and five, and now I just need to identify and unlock the oculomotor cistern, and then we're going to get that space. Using that, then I can remove that tent, go all the way to the prepontine cistern, and debulk that tumor, and at the end, we're going to get the view of the basilar trunk and SCA, PCA, and basilar apex to achieve then a complete resection. And then, of course, the reconstruction. And this is the post-op scan. To finish, I'm going to just touch on concepts of the endoscopic and the nasal approach. And we all understand transsphenoidal, opening sphenoidal sinus, exposing the sella, identifying the components of the dura. And then here I'm going to demonstrate this without a transpterygoid extension. The first aspect is the superior compartment, and this is the one just on top of the horizontal segment of the carotid. And what you can see here really will be three structures: the posterior clinoid process and its tip, with a 30-degree endoscope on the top. You're going to see the interclinoidal ligament, and just lateral to it, the oculomotor nerve. So if you're working above the horizontal segment, the one nerve you got to think about is the third nerve, which will continue to run just lateral to the anterior genome. And you can open the roof and you can go to the ambient cistern and paramedian cistern as well, which is the same thing that you saw from above, but from a different perspective. The posterior compartment will be located just behind the paraclival segment of the carotid, and that one will be in key relationship with this little piece of bone, which is the petrous process, this sphenoid bone, and with the sixth nerve as it runs from the prepontine cistern, Dorello's canal, and then inside the cavernous sinus itself. From above, we see all of that as well, but we start from the back part. So we start from the cistern, Dorello's canal, and then the cavernous sinus. And then, of course, endoscopically, V1 is lateral to the 6, and transcranially is exactly the opposite. So this 6th nerve is a medial to V1. Finally, the anterior inferior space, and that I combine in one because really there is no clear separation to me here. And what truly matters, surgically speaking, is the relationship with the sixth nerve. It is important to remember that the sixth nerve is inferior lateral to the carotid. So if you respect the midpoint of the line of the horizontal carotid, you're not going to be crossing the sixth. And the sixth nerve, always remember its trajectory, which goes from inferior to superior and medial to lateral, and use your instruments following that direction as well. So go from this direction, don't go in this direction like this, because you can end up transecting that nerve during your dissection. Of course, if I were to mobilize that carotid and open the proximal dural ring all the way to the distal dural ring, we can rotate the carotid with the care to mobilize or transect the inferior lateral trunk, and then you can see third, fourth, and sixth going into the superior orbital fissure. So just to finalize, cavernous sinus is key in pituitary adenoma surgery. See, this patient had 2 surgeries in an outside facility, had this recurrence that once again was inside the cavernous sinus, and then causing growth again, compressing the optic apparatus, pushing the gland to the right and to the top, and was, as you see, like you're going to see a challenging case here. Why was it challenging? Because it was not a simple, just debulkable soft tumor. The key points here, once again, bone exposure and identification of your anatomical landmarks, which in this case would be vascular anatomy. And here, namely, will be the clinoid segment of the carotid, which is fixed on the top, and I needed to see the paraclival ICA. So dura is open. We can mobilize that area. I map with the Doppler that segment, and then I need to find the paraclival ICA as well, which I can't see initially because it's blocked by this tumor. So initially somewhat soft, and then you can see that becomes a very fibrous piece on this side. I try to mobilize and work with your suctions. It doesn't work that well. And then I really need to go on a step-by-step using Doppler and scissors until I get to the cavernous sinus. Here I got some venous bleeding. That's a big win because it gives me the lateral aspect of that tumor. And then I can start to expose more laterally to try to rotate that tumor. And then the tumor, the surgery really becomes a win when we get to this point, when you see this white tissue structure, which is the vertical segment of the carotid in the cavernous sinus or the paraclival ICA. I can mobilize that. How do we mobilize that? By understanding its anatomy. So you need to go from bottom up, cleaning the anterior part of that vessel where there is no branches arising from. If I go from the bottom, like in the back, I can get the meningohypophyseal trunk. And here, from lateral to medial, following the clinoid segment on the anterior genome of the carotid. So bottom up and lateral to medial, that gives me that perspective. And then here, after dissecting, we can get all this nice view of the carotid. You can see that by separating this tumor, we can go and get this nice view that shows the vertical segment, posterior genome, horizontal carotid, and anterior genome. And the only structure that was really key, and you got to think about it, is the origin of the meningohypophyseal trunk, because that was the one vessel that could have given me a lot of work, especially if I were to dissect that aggressively and cause an injury. You know, avulsion of that trunk is basically a carotid injury. So that was the point that was most of work. But after doing that, we could achieve, a very nice resection, basically a gross total resection of this very invasive tumor. This patient is now being followed and doing well. And then finally, to finish the very controversial topic of resection of the medial wall of the cavernous sinus, which is a work that we have been doing as well. The key points would be identification and exposure of the anterior wall of the cavernous sinus, identification then of the medial wall. This inferior lateral space is mapped with a Doppler. You can open that area and then identify this medial wall. Afterwards, you can just transect close by to the distal dural ring and the base of the sella. And the one key structure at the end is the inferior hypophyseal artery that is just in front of the dorsal clinoidal, posterior clinoidal process, and that completes your dural removal. And we have been using that for very selected functional tumors. It's basically 10% of the practice only, so it's not for every case. It requires a lot of expertise and time and training in microsurgery. So I'm just going to show this one case. It's an acromegaly patient with that tumor. You're going to see here that in this case, I came with the mindset to explore and expose the cavernous sinus. So the cell is being exposed. Here I'm going to go to expose the carotid. I like to do that from lateral to medial. So I like to unroof the carotid. This is mobilizing the medial clinoid process here. So to get access to that superior compartment. And then this unroofing allows us to get all the way to the paraclival ICA and to expose basically the entire carotid on the side. So you see here, the carotid is exposed, the anterior wall as well. In here, I can just open this residual anterior wall, the carotid clinoidal ligament, and that will give me the entire view of the carotid. So horizontal, posterior genial, and vertical segment. I continue to open the inferior intercavernous sinus, and then I can go to do the classic maneuver, so opening the sella, identifying the normal pituitary gland, and then debulking the tumor. And after this debulking of the tumor in the sella, you can see here the wall that we're going to call the medial wall of the cavernous sinus. And then I can go ahead and separate that from the carotid itself, and then proceed with the cuts that I had described anteriorly previously. So the superior cut that is being done here. And then I'm going to go ahead to proceed with an inferior cut, just medial to the carotid. So after coagulating the inferior hypophyseal trunk. And then I'm going to remove that medial wall here and send it to pathology. So no CSF leak, no carotid injury, and the pathology demonstrated that there was invasion of this tissue here. And more importantly, this patient achieved disease control with the techniques here demonstrated. So in conclusion, the cavernous sinus is one of the most complex skull-based regions, and complications may be unforgiving. So understanding of anatomy and surgical technique is key. A multidisciplinary assessment is necessary, and surgery must be discussed. We can resect the tumor. Sometimes the tumor is to be resected. Sometimes we can decompress the cavernous sinus and achieve good results. You got to master endoscopic and open approaches, and definitely anatomical knowledge is key for this. Thank you very much.
Thank you, Joao. Very nice lecture.
Thank you.
On nice
Appreciate
cases. So you are a believer of the medial wall of the cavernous sinus. I can see that.
I believe that in very selected cases we should consider that. I mean, I did include some. I think that there is one specific case of Cushing that I show around that is interesting. But I think that the big thing here for medial wall is like as I was saying, since November 2021, that's when I started to do those cases here at Mayo. I've had about 220 pituitaries now, and only 26 were medial wall resections. So I think that the big thing is very carefully selection of patients that can benefit of it. I think the big problem is when we try to generalize too much. I think that's when we expose patients to risk. And I think that's a little bit of the concept. But as I said, I really don't know what would be the right name, because honestly, I haven't studied the histology as you demonstrated. So I think maybe it can be just a mesenchymal thickening of tissue in that space. So I really don't know about that. But what I know for sure is that it's not a technique that should be just considered at all times. It's not a technique to be attempted in the beginning. It is definitely a much more complex technique than the usual, approach that we do for 90% of the cases, and therefore should be used very carefully and very selected. And I think another important point is that I'm doing it as I demonstrated, but we do not have, and I don't know anybody that has long-term outcomes to demonstrate the impact of this, and that is still to be studied. So right now I'm happy with the selected patients that we did, but I still need to collect data in 5 or 10 years to demonstrate if that really had a significant impact, especially when we have radiosurgery also available.
Thank you, Joao. So let's move to the next lecture. It's Paolo Di Russo, who is going to talk about surgery into the cavernous sinus and also its evolution over the year. There have been significant change, and talking about the resection of the medial wall is definitely one of those changes. And to look at the evolution is definitely interesting. Thank you, Paolo.
Thank you, Sebastien. So I will start with a brief presentation of me because I'm not so famous as you all. So I work in this place. It's called Neuromed in Froelich. It's a very small town, as Sebastien already said, but we have a big department of neurosurgery. We have 5 OR for neurosurgery, more than 2,000 procedures each year. It's one of the biggest in Italy. Actually, it's like when you walk, when you drive in the desert. You see a picture here of the Morocco desert. You drive in the desert, you feel that you get lost. At the end, you find this beautiful oasis where you find the water and some relax. That's the same thing that you can, same impression that you have when you come to our place. So I don't have any conflict of interest. Americans like to always to put conflict of interest in the presentation. I can tell that my conflict of interest are these 2 guys. I spent a lot of time with them and I learned a lot from them. We don't have only the department, we have also a nice lab since 2021. And I participated to creating this lab with all the colleagues that you can see in this paper. Finally, we had the possibility to start a collaboration with Andrea Cardia from Switzerland, from Switzerland and Milan with this fellowship project. So we have fellows now that are training in the lab. I have to thank Luigi Moro for helping doing this presentation. So we will start and we will try to walk and drive around ears. Is a long journey from the beginning of the surgery of the cavernous sinus to the modern area. So at the beginning, this is a brief summary of what we are going to see. At the beginning, cavernous sinus surgery was considered not possible, was considered a no man's land, the cavernous sinus. Then, after years with these 2 surgeons, White Parkinson and Vinko Dolenk, cavernous sinus surgery became possible, and aggressive surgery has been done to treat vascular and tumors in the cavernous sinus. Then things have been changed among years, not only for cavernous sinus, for every type of surgery, with the goal to achieve a functional result, not only the removal of the tumor, which still is the most important thing, but also functional result, which is really important for cavernous sinus, considering the amount of nerves that are inside the cavernous sinus and the vessels, important vessels. So everything started with the critics done by John Tew and Van Loveren, which realized that there's some infiltration of current nerves was done also by benign tumor by meningiomas. So it's a balance between resection and function for the patients. So many different lesions can arise in the cavernous sinus, vascular lesions. Some of them are treated in majority cases with endovascular procedures nowadays. A lot of neoplastic lesions, meningioma from benign tumor like meningiomas, schwannomas, pituitary adenomas, 2 most aggressive tumor. And we had recently a case of very, very aggressive teratoma of the cavernous sinus, which had a repeated regrowth, rapid regrowth for this patient. To conclude, another type of lesion that can involve the cavernous sinus are the inflammatory lesions, which Tolosa syndrome is the most common one. So considering that I have the most boring presentation, maybe the less anatomical, I put every once in a while some slide of the cavernous sinus or some dissection that the fellows has done in the lab. So let's start with the original surgery of the cavernous sinus. So as I said, it was considered a no man's land for many, many years. And this is because of the misleading term of the cavernous sinus. Actually, the guilty of this was Sir Winslow, that attributed this term cavernous sinus, making a comparison with the corpus cavernosum of the penis. Finally, White Parkinson realized that there is no need for erectile tissue in the head. How he arrived to understand it was not the corpus cavernosum, but doing a lot of dissection in the cadavers. And he proposed a lateral cellular compartment instead of cavernous sinus for the name of this jewel box, as they said. If you look at the first description from White Parkinson, it goes back to the 1964, but the case that is described is even older, in the late 50s. He realized in describing the paper for the first time the infratrochlear triangle, which took after his name, the Parkinson triangle in between V1 and the trochlear nerve, and he was able to go inside the cavernous sinus to treat these carotido-cavernous fistulas after done more than 200 cavernous sinus dissection in the cadavers. The problem was that the Parkinson approach at the beginning was a pure intradural approach. So he understood that the cavernous sinus has a two-layer of dura, the dura propria and the periosteal dura, but he addressed the cavernous sinus from a pure intradural approach, as you can see from this drawing. So the retraction, the direct retraction of the temporal lobe increased the already high level of the risk. This is an image that shows you very clearly which is the area of the Parkinson triangle. You see the fourth nerve is dissected here. Normally, it's very closer to the third nerve. We have to wait the 1980s with Vinko Dolenk to understand better that the cavernous sinus could be approached directly with the extradural approach, opening the dura only for some extra tumor from extra tumor removal. So Vinko Dolenk combined the pterional approach with the subtemporal approach with the goal to expose the intrapetus portion, the intracavernous portion of the carotid artery to treat the beginning vascular region and then to treat also meningiomas and mesovalnomas inside the cavernous sinus. The same as it was for White Parkinson, Vinko Dolenk learned everything about cavernous sinus in cadaver dissection, and then it moved from cadaver dissection to the real surgery. And he combined this extradural approach with the intradural approach, which now was for many years, and now things are changing, and we will see how was the gold standard to treat this kind of lesions. Just to summarize a little bit the Dolenk approach, JP already said something about that. The first stage is purely extradural. So the peeling of the lateral wall of the cavernous sinus is the most important stage of this to separate the intradural portion of the tumor from the intracavernous portion of the tumor. And the second phase, maybe not necessary all the time, but helps first to identify the border of the tumor in the superior and middle aspect, and it can be useful to remove the real intradural portion of the tumor. So let's see a little bit. This is the real original description from Dolenk, when he explained very well that preserving the inner layer of the dura helps to reduce the risk of the morbidity of cranial nerves. The dissection of the lateral wall of the cavernous sinus from Dolenk start from anterior to the cutting what he called the dural tent, which now we call the meningorbital tent, with this curved scissor, which may put some risk to the cranial nerves inside the superior orbital tissue. So different techniques have been developed later from Sebastien Froelich and also from Jacques Marcos to change a little bit the starting point of the dissection from V2 to reduce the risk of damaging the nerves inside the superior orbital fissure. This is the drawing of the original paper from depending on the section of the tumor, as I said, the tumor could be followed or both intradurally or more posteriorly, including also a anterior petrosectomy in the approach for a case like this for a dumbbell-shaped trigeminal schwannomas. So the point of the length was that mobilizing the lateral wall of the cavernous sinus was possible to remove the majority of the parts of the tumor from the Parkinson triangle, which normally is the widest one, or to use other triangle. It depends depending on the tumor position. Actually, we can use so many nomenclature for the triangle. The most important thing is that we have to choose the triangle where the tumor is more superficial and comes toward us in our direction. Another important thing that comes is very clear from the length description is the compulsive hemostasis. Actually, at the time that time it didn't have any surgical Surgiflow or other name. I don't remember other name of this hemostatic agent. So he needed a lot of Surgicel and patients to have the possibility to obtain a good hemostasis to keep on going with the tumor removal. As I said, this approach can be followed by a second phase, which is the pure intradural phase. We will see a case later with the longitudinal opening of the dura along the Sylvian fissure to remove the tumor if it's intradural also, or to just locate the border, the medial and superior border of the tumor. These are some dissection that show you the starting point of the Dolenk approach. So the meningorbital band is cut, and you can see the nerves inside the superior orbital fissure. Then the meningorbital band, the middle meningeal artery posteriorly is cut to expose, to include the exposure of V2 and V3 and the cavase rhomboid fossa. Then the drilling of the anterior clinoid process is performed, and also the drilling of the cavase. This is the complete Dolenk approach, and then you can see the beautiful final images that you can get once you have all the bone work done. So you can see all the extradural and intradural parts. And at the same period as Dolenk was doing this dissection and these cases in Japan, Akuba started to do the same strategy to approaching with the interdural approach the tumor and the vascular lesion of this region. The problem was the communication, maybe, because as you can see, this paper, only the abstract is in English, the other paper, the rest of the paper is in Japanese. So it's probably they started together to have the same feeling and the same strategies for cavernous sinus, but the difficulties in the language may have played some role in that. So the same in the US, Lavin and Shekhar started in the 80s to do this kind of cases, and he pointed out a very important point about the cranial nerve monitoring, which is crucial for this type of surgery. Nowadays, it seems normal for us, but at those times it was very nice insight to use the monitoring for this type of surgery. Another nice things that you can find in this paper is that the venous bleedings can lead us and can make us aware of where we are exactly, because when we have a real venous plexus bleeding, while we are doing the resection, we can understand the border of the tumor, because it means that we completely remove a tumor in one point, because the venous bleeding starts to start. But this is an upper view of the oculomotor triangle of the cavernous sinus from above. Now we are running toward our period. So in the last part of the 80s, Osama Meftis, which was doing a lot of intracavernous cases, started to question itself about the necessity, the need, and the rationale about the direct cavernous sinus surgery, because he realized that some morbidity that he had after the cases was purely related to the approach. So we arrived to the middle of the 90s with these two important papers from the same group, John Tew and Van Loveren, which understood that some infiltration of the cranial nerve was done also by benign meningiomas. So they concluded telling that the hope to a total removal of meningioma may be useless in terms of advantage comparing with the morbidity for the patient. And then, as always, they started with the lab, with a paper in the lab, and they tried to understand, to review their cases, intracavernous cavernous sinus meningiomas. They came out with this conclusion, telling that the aggressiveness of the approach should be tailored to the patient according to the involvement of the cavernous ICA, the preoperative presence of cranial nerve morbidity, and they concluded telling that subtotal excision followed by eventually radiotherapy should be a good strategy, at least for short-term controlling those period. Year after years, other group, here we have some paper coming from Uğur Ture in Istanbul about a non-meningeal tumor of the cavernous sinus, and they came out with the same conclusion that trying to achieve complete resection also for benign tumor like pituitary adenomas and schwannomas may increase a lot the risk for the patients. The same, Mark Sindhu came out with the same conclusion. We are running towards 2007, and there is no advantage of resecting the intracavernous portion of the meningioma after statistical analysis and a follow-up of the regrowth of the residuum inside the cavernous sinus. Here you can see the same, the infratrochlear trunk and the relationship that Kentaro already showed us with the sixth and the fourth nerve in the Parkinson triangle. Now we arrive to the strategy that we prefer to have today for tumor invading the cavernous sinus. So the risk of tumor recurrence are persistent even also after closed-total resection because of infiltration of the intracavernous structure and the morbidity, the vascular and cranial morbidity is too exaggerated. So they came out with this conclusion telling that stereotactic radiosurgery is the key to get has to follow the resection of the tumor in this area. Going closer to us, 2014, we have this nice paper published in Neurosurgery that compared the old series from Dolenk, Abdelaziz, Sindhu with the more recent treatment. This is a paper that which dramatically in favor of the gamma knife. I think that the good balance was later found by other paper that we see. Atul Goel that we have maybe in the webinar today also published a lot about the cavernous sinus from the early 2000 and also mostly about the hemangiomas of the cavernous sinus. I think this is a very honest paper because if you go to the conclusion about the outcome of extraocular movement function, they clearly say that the majority of the patients do not recover from the preoperative deficit, and they may have some additional worsening of the ocular movement after surgery. This is one of the last papers published about this topic. Is the consensus statement from the ENS cut-based section. You can see many surgeons from Europe and not only from Europe, and they concluded telling that whenever surgery is indicated, so according to the size of the tumor and the symptoms, the current trend should be to offer a good decompression for the patient followed by radiosurgery. I will skip all the level of evidence that has been proposed. This is an interesting paper. I would recommend everybody to read it. Let's go to the end of this part. This is a nice view with the anterior clinoid process still in present. When we talk about the cavernous sinus and transcavernous approaches, we cannot avoid to talk about the surgery that is done by Eli Grift, which is treating mostly not only vascular cases, but mostly vascular cases. So you can see a lot of videos published about this. This is clear that the first indication for this type of vascular lesion is without any doubts the endovascular treatment. Some cases recur many times after endovascular treatment, or some cases cannot be treated. So still is necessary to train ourselves with microsurgery to be able at least to approach these cases. This is the last one paper, which was published in 2023, which talk about the learning curve, which is very interesting. The learning curve, they divided 4 levels of difficulties in this paper to train ourselves to for the intracavernous approaches. Another thing that we cannot miss, but already JP talked a lot about that, is the rule of transsphenoidal surgery. This is a very nice paper, and I think it's still an honest paper because they say that the capability of remove to obtain a gross total resection from the cavernous sinus was not so high for adenomas invading the cavernous sinus. So let's conclude with this part here. So what to do in case of regrowth after surgery radiotherapy? So if the strategy now is to offer decompression and put our fate inside the hand of radiosurgeons, what if we have a regrowth after this strategy? So that's the reason why we still need to train in the lab to have good microsurgical skills to be able to attend these very rare cases. And you can find this paper of aggressive removal of cavernous sinus after multiple recurrence of tumor. The first one maybe to propose this strategy was Bernard George from Lariboisier in Paris. And he proposed his series about cavernous sinus exenteration for repeated recurrence, not only of malignant tumor or cavernous sinus, but also for recurrent meningiomas of the cavernous sinus. When you read papers, sometimes it's very interesting to read also the comments about from other surgeons, and you can amuse yourself sometimes because you can see that they are not always, they don't always agree each other, as you can see here in this paper. So I will conclude with one case just to make everything I just said real and not only in dogmatic. So this was a case that arrived to us 2.5 years ago. As you can see, it's an intracavernous tumor. The patient had a trigeminal pain in B1, complete palsy of 6th nerve and partial palsy of the 3rd nerve. The first I saw this tumor, I was quite sure that it was a schwannoma, trigeminal schwannoma inside the cavernous sinus because of the shape of the tumor and this small cyst inside it. So after discussion with colleagues, we decided to go for a extradural, intradural approach in Dolenc style. With the peeling of the lateral wall of the cavernous sinus. If you look carefully at the MRI, you can understand and try to identify and distinguish the real intracavernous portion from the portion which is inside the 2 layer of the tumor. As you can see here, in this case, it was possible to see this on the T2 scan. And on the CT scan, you can see this bone scalloping that made us thinking about that it was a schwannoma. Actually, at the end, it was not a schwannoma. So this is the patient positioning. Definitely, intraoperative monitoring is the key, and you cannot skip it when you do this kind of surgery. We perform a one-piece orbitofrontal craniotomy, preserving the zygoma, doing an interfascial dissection to push lateral the temporalis muscle. So let's see a little bit the video of this case. So as you can see, it was an hemangioperisitoma, grade 2 tumor, solitary fibrous tumor. So this is after the craniotomy has been done. So you flash down and you drill down on the sphenoid wing until you get to the clinoid. In this case, the tumor already did the part of the approach because the clinoid was no more there and the petrous abscess was not there because of the presence of the tumor. So first step, you open the superior orbital fissure so you can identify the nerves inside it. So it's easier and safer to cut the meningorbital and under direct view of the cranial nerve inside the superior orbital. So you can start your peeling. This is here. You can see the superior orbital fissure, and you can start to see the two layer of the dura. The presence of the tumor definitely will create a pressure. So with this pressure, it may be sometimes difficult to start the peeling, but once you start it, it's not so difficult to keep on doing it. And the presence of the tumor itself reduces a little bit the bleeding, so you can keep on doing the dissection. You identify GSPN posteriorly to relax it a little bit to avoid any traction on it during the dissection. I tried to keep on doing the peeling over V3, but it was not so easy there. So I came back to V2 and V1, where the plane for dissection was easier. So you have to push a little bit, make a traction. So when you see a small band of dura, you cut it with the microscissor to avoid any excessive traction. So you can see we start to see V1, V2 here, gasserian ganglion. You see the bulging of the tumor, which is inside, and you can see the tumor is coming out directly from the Parkinson triangle. So I like to not use any spatula for this kind of cases, because even if you have the dura protecting the temporal lobe is still at risk. So I put some stitches as I learned from Sebastien. So I try to understand where was the most easier part to remove the tumor, and definitely it was the part where the tumor was more superficial. So we went the beginning in between V1 and V2. Then we started to relax the tumor a little bit closer to V3, but the pressure was so much, so we went back to the beginning. So we used the Parkinson triangle between V1 and third and fourth cranial nerve. So I immediately we realized that was not a schwannoma, because it was more a fibrous tumor, maybe a meningioma. At the end was in a mandibulocytoma. See, once you go ahead with the dissection, the bleeding from the cavernous sinus starts, and you have to be very careful to not push too much the dissection. I like to use this kind of internal decompression, which is the ring curette, the same that we use for pituitary. Once I was not so comfortable anymore, I put some Flozil inside, and I opened the dura in blank fashion style along the superior, along the cingulate fissure, not to remove the tumor, just to locate a little bit more where the medial and the superior part of the tumor. So you can see here, this is the inner part seen from intradural. Once we understood this, we went back extradural to remove the other part of the tumor. As you can see, there was a lot of tumor still there. So opening the dura doesn't help only to remove the tumor, but also to understand better the relation of the tumor. As I said before, once you see venous bleeding from intracavernous portion, you understand that in this part, that is the lateral part of the tumor, we finish. Then we arrive to the bottom of the tumor. You understand it because you know where is the anatomy. So you saw the sixth nerve, the bottom of the surgical field. You protect it with the cotonoid, and it means that after the sixth nerve, you have the intracavernous carotid artery. And it means that you finish your tumor removal. This is the final view with a nice decompression obtained. I like to close this is the final view. As you can see, V1, V2, V3 in the tumor cavity. Then the dura is closed at the watertight fashion, and then I like to put some gallia on the cranial base and then some fat to avoid any risk of postoperative fistula. This is the result. Just to going back to what we said, the goal is to obtain a nice decompression and to leave some part of the tumor around the carotid artery to avoid any problem. And you see what is the result after stereotactic radiosurgery, 32 fractions. So you see the complete shrinking of the remnant tumor, 2 years and a half follow-up now for this patient. When you do this kind of surgery, you have to expect from the patient some deficit after surgery. If your monitoring is good during surgery, you can tell and reassure the patient that it will be something temporary and not definitive. So you see day 2 post-op, the eyes completely closed, start to open day 5 after surgery, and this is the last patient that I took to this patient, 14 months after surgery, no trigeminal plane, complete palsy of the nerves that he had before, and he went back to the preoperative situation. So I finish. I remind you that if you need some information about our fellowship program, which is founded, which is good, you can email us using this email. And I want to conclude with this because everybody of us we have lab. We like to maybe to publish something. Sometimes we push too much publication. So I want to go back to this observation done by White Parkinson. So it first saw something that was not completely convincing him in a case. Then he went to the lab to do anatomical observation, and then he went back to the lab. This is the journey that we have to do. We don't have to start with the way, okay, I want to publish this, and then I find a way in the lab to publish something sometimes a little bit crazy. So starting from the case that which need to inspire us, then going back to the lab to verify our doubts in the cadaver, and then if we find something good, we can put it back on the patient. So this is I conclude.
Thank you, Paolo. Very nice review of what has been done, what is done now, and what should be done in the cavernous sinus. Very nice. An interesting case is hemangioperisatoma. It's not so open. If you had the opportunity to do a biopsy in a case like this, and you have the diagnosis, you would go for surgery or directly for radiation therapy?
I think I would go anyway for surgery because the patient had a V1 pain. The tumor was 3 centimeter tumor, so I think it still necessitated decompression before radiosurgery. And then also radiosurgery works well if you do a nice decompression.
So let's move now to the next lecture. We have the privilege to have Linda B with us. Linda is from Harvard, great surgeon and great scientist also. And she will discuss about neuromonitoring of the cavernous sinus, which is definitely key for this type of surgery. We've seen it with the cases shown before. The risk of those surgeries is significant. So having great monitoring is definitely great. Thank you, Linda.
Thank you so much for organizing this, and what a pleasure and honor to join this group on the cavernous sinus. Great. I wanted to touch about the evolving techniques for neuromonitoring the cavernous sinus surgery. As the previous lecturers have highlighted, of course, anatomy is the basis of everything that we do, especially in the cavernous sinus when there is risk everywhere, as we both in the cavernous sinus, to the cavernous sinus, and through the cavernous sinus. But for those who venture there, having an adjunct, having a GPS to that road can often be helpful. And neuromonitoring, I think, is one of the powerful tools that we have. The classic modes of neuromonitoring would be broken into two categories: that of monitoring, which is the assessment of the anatomic and functional integrity of cranial nerves and other neural structures, as well as mapping, which is the interrogation of upcoming risks in those neural structures. In the broad overview of the general neuromonitoring categories that we use in daily life in neurosurgery include the monitoring of somatosensory evoked potentials, motor evoked potentials, including for supratentorial and infratentorial surgery, that of the cranial nerves, most commonly measuring EMG responses as we directly stimulate a nerve, but also trigeminal somatosensory evoked potentials, corticobulbar motor evoked potentials, BEARS, amongst others, and increasing kind of interest and I think experience in the various reflex circuits that run through the brainstem from the cranial nerves, which also provide a powerful set of tools, especially in cavernous sinus surgeries. So I'll delve into some of these in more detail one by one. First, this is an illustration of the traditional monitoring modalities that I think the world at large has the most experience with, including SSCPs, motor evoked potentials, BEARS for both cranial nerve 8, but also as a coarse estimate of brainstem integrity, and EMGs. In the cavernous sinus, cranial nerves 3, 4, 5, 6 are particularly keen. But sometimes individuals who use these express frustration at either false positive or false negative artifacts. In our experience, a couple of maneuvers have helped us clean up the sensitivity and specificity of our signals. Taking the oculomotor nerve as a first example, this is an illustration of subdermal electrodes placed into the superior rectus. Another common location would be the inferior rectus. The rationale for perhaps a superiorly placed electrode, which is just sliding underneath the orbital rim as if sliding a central line underneath the clavicle, is if one wanted sensitivity more than specificity. For example, identifying the global gestalt of capturing both superior rectus and the superior oblique, 3 and 4, in a single electrode. Putting in the inferior rectus allows individuals to segregate the superior oblique, or 4, from the inferior rectus, or 3, for those who want specificity. We found that the use of insulated electrodes significantly improves specificity by reducing far field potentials, and also, especially if one were to move towards cortically evoked motor evoked potentials, becomes essential in that category. For the abducens nerve, especially when concurrently run with high density coverage of 3, 4, 5, and 7, a common place to put the ground electrode, of course, the electrode itself is placed into the lateral rectus, but the ground is often placed just lateral to it, somewhere nearby. By placing that ground to the contralateral side, we feel that it reduces cross-contamination artifacts from ipsilateral facial responses and allows greater distinction of these. Another point that was recently made by the Mayo Group in an elegant publication in Journal of Neurosurgery is that the belly of the rectus muscle is about 25 millimeters from the lip of the orbital rim. And so using a longer electrode, about 25 millimeters, gives better responses. And we've also verified that in our experience as well. Moving to the trigeminal nerve, which is particularly intimate with the cavernous sinus, both on the outside and the entryway and in various directions. The most common perception of the trigeminal nerve for most folks is looking for V3 and EMG responses. But the trigeminal SSCPs, which were actually first introduced several decades ago, can provide a powerful adjunct, along with cortically evoked or cortical bulbar motor evoked potentials for V3. And these days, increasing experience with a number of trigeminal-based reflexes add to the armamentarium of assessing for specific branches of the trigeminal nerve, as well as their integrity with other kind of brainstem counterparts. And so these, I think, add a layer of sensitivity, especially in more complex lesions of the cavernous sinus and beyond. Cortical bulbar motor evoked potentials first gained, I think, reputation and increasing experience starting from about 20 years ago with the report of their great role, especially in vestibular schwannoma surgery. They are best described for the facial nerve, specifically stimulating the cortex and recording from the face through the loop of the entire pathway from the cortical representation of the face through the brainstem and then out through the facial nerve itself. And for some individuals, cortical bulbar motor evoked potentials for the 7th nerve may be even more sensitive than EMGs or other sort of pathologic responses that could be observed during vestibular schwannoma surgery. Why this is relevant to the cavernous sinus is because cortically evoked motor evoked potentials can, in theory and in practice, be evoked for any motor muscle related to the face, including 3, V3, 6, 7, 10, 11, 12. Now, one will quickly point out that there is no cortical representation for the extraocular muscles in terms of 3 and 6. And so when running these responses for cortically evoked motor evoked potentials from the scalp or the top of the head, likely this is stimulating the nuclei and not the cortex, and then subsequently being recorded through the peripheral extraocular muscles. However, I think as a surgeon, regardless of what it is stimulating, as long as it is through that kind of network or pathway arc, then it provides an additional tool for us to assessing integrity. So that monitoring aspect beyond mapping of the nerves, when we actually are able to get our probe on it, is really, I think, a helpful adjunct. We looked at cortical bulbar motor evoked potentials because, and we're, did a systematic review of all publications for it. And across the 80 publications that we could find to date, it was great to see that they are represented from all around the world, and that there is increasing experience from many, many great centers, but really mostly focused on the facial nerve still. You can see some experience with other branches, with only, I think, one paper or so published on cortical bulbar motor evoked potentials as applied to the fifth nerve. And that the majority of these experiences do relate to the brain, skull base or posterior fossa CP angle. However, there's also some controversy when it comes to the use of cortical bulbar or cortically evoked motor evoked potentials. For one, even the title of what this type of motor evoked potential should be called varies. So this is the word salad map of every possible designation that we found across the papers. And you can see that many, many different terms exist across the literature with very little homogeneity or standardization. The methodology of applying cortically evoked motor evoked potentials also varies. Whether folks use subdermal electrodes versus pegs, insulated versus non-insulated, hemispheric stimulation montages versus interhemispheric, and then the type of stimulation parameters and how they detect artifact using a single double train and or not. It really is all over the map. That probably in part then corresponds to the varying performance that we see across the literature and across different centers. We hear animated discussions in some conferences for individuals who are either pro or against the use of cortical bulbar motor evoked potentials. And you can see that the sensitivity or specificity across these major muscle groups are really quite scattered. For us and our team, we spent the last 5 years optimizing cortical bulbar motor evoked potentials for our uses, and really have derived the most consistent, I would say almost perfect consistency results with a combination of these 3 strategies, which is using an interhemispheric stimulation with a linked quadrupolar setup, most commonly used for motor evoked potentials, but we now apply that for the cortical bulbar motor evoked potential setup, having very tight medial clustering of the stimulation electrodes, and critically using insulated recording electrodes. Having these 3 things together give us really a dramatic improvement in the monitoring responses. And so putting that together, this is an example of for using insulated electrodes for 3 and 6. You can see that insulated electrodes are a little bit more floppy and thin than the subdermal electrodes that we're perhaps more used to. In this particular case, I chose to use the superior rectus and going a little bit more medial to capture both superior rectus as well as superior oblique. Again, looking for sensitivity rather than specificity. Doing the inferior rectus is a similar strategy. Likewise, in cranial nerve 6, using a longer electrode, which is not illustrated here, can be very, very useful for improving the detection. And that's just very simply sliding that to the side of the lateral rectus. You can see it only takes a couple of seconds to insert this, and really can be done by anyone. Protecting the globe with a finger, spacing out the tips of the insulated electrodes because they are a bit more floppy so that they don't touch, and then inserting it in, just sliding it along the side of the lateral orbit and going from there. When it goes beyond sort of the monitoring for the integrity of the function, mapping is another critical tool. We are most used to this in cranial nerve related surgery, including the cavernous sinus, by using often a stimulator that has some sort of tip that allows electrical conduction. This applies to the brainstem and for the other sorts of areas that we do mapping, including in the corticospinal tract supratentorially. An alternative that has gained a lot of traction in supratentorial intraaxial surgery is to use a monopolar stimulating suction, such that both the tumor resection and the continuous interrogation of the critical structure, whether it's the nerve or the corticospinal tract, can happen simultaneously. And so for many people, there's different ways of doing this. For us, the monitoring physiologist allows to tell us exactly when they hear something at the exact stimulus there. Complementary to these classical sort of techniques, I think, is an increasing experience and interest in brainstem reflexes. And this is powerful, especially for cavernous sinus surgery, because many of these rely on the fifth nerve, including V1, V3. And so I'll highlight this in an example coming up. So this is a cavernous sinus meningioma that I'll just quickly broach, not for the sake of the surgery, which was already beautifully discussed, but the sake of what potential modalities do I find useful in a tumor like this that is clearly within the cavernous sinus. This is a young woman who presented with increasing extraocular movement dysfunction in that left eye, as well as eye pain. And you can see the hyperostotic anteroclinoid and the engulfment of her related nerves. In this particular case, I used the trigeminal SSCPs to assess for V1 to V3, EMGs for the third V3, 6, also 7, but related to the cavernous sinus portion, cortically evoked motor evoked potentials for 3, V3, 6, and then as well as SSCPs and MEPs given the encasement of the carotid artery. The extent of the resection, is at least through the transcranial approach segment of this, is really limited in some ways for me by the adherence to the vessels, but I think overall we achieved the goals of surgery. But most reassuringly for this patient is that with the appropriate monitoring and mapping, we're able to significantly improve her extraocular movements despite the encasement by the tumor. You can see the preoperative motility duction measurements versus they're almost perfect on the early postoperative visual exam. Another common example that we might encounter in terms of cavernous sinus tumor surgery would be trigeminal sternomas. And trigeminal sternomas, especially large ones for us, we've had increasingly appreciation for not just using trigeminal SSCPs, V1, V2, V3, or EMG for V3, but also incorporating some of these brainstem reflexes. You can see in this particular patient who presented with facial numbness in mostly the V2 and V3 distribution. During her surgery, her trigeminal SSCPs were mostly stable, but V1 took a 30% decline at the end of resection. Her blink reflex actually also diminished, and post-op, her V2 and V3 improved, but her V1 was more numb than pre-op. And so, a lot of these modalities we're still gaining experience in, but I think collectively with the body of experts around the world who are increasingly performing these surgeries, I think we have a lot of opportunity to experiment and improve our validity and experiences with these sort of more evolving monitoring and mapping techniques. All of this work is done with my two dedicated neurophysiologists, Matt and Mitali, who enable me to venture to territory that I otherwise would be hesitant about. So thank you so much.
Okay. Thank you, Linda. Can I make a question to you? So just to share our experience, we do the same for the oculomotor monitoring for the nerves. We use it very often. I learned it in Paris because in France they don't have the specialty that put the electrode all around the head. So we do ourselves. We did ourselves. So when I came back, we started to do also in my place. But the electrode in the orbit, in the muscle, in the extra ocular muscle, we put directly inside the eye. So we don't put it transcutaneous. Do you think there is some different? Actually, we didn't have any problem with the eye, no irritation. As far as I remember, maybe just one case, maybe when I came back, that was put away too fast after surgery. But otherwise, we find it very well to put directly to look the muscle inside the orbit and put it directly. Always the third and sixth.
Great, thanks for sharing.
Okay, so now it's time. Sebastien is still there, maybe yes. So we go to now. It's time of who is the next now? I think is
It's me,
open. Okay,
Sanford.
please go and share. Thank you. Can you share your presentation?
Yeah, did you see my screen now?
Yeah, thank you, Sanford.
Thanks, Sebastien and Paulo. And today I would like to talk about the microneurosurgery of the cavernous sinus. And first, I would like to introduce myself. I have done the fellowship in Little Rock since 2007 to 2009. And I had three great mentors, Professor Yazakio, Professor Mafti, and Dr. Krish. And I will skip the detail of the anatomy of the cavernous sinus because JP and Kentaro have done a great job of talking about the anatomy of the cavernous sinus. But as you know, the cavernous sinus, the anatomy is complex. So when you do the surgery in or around the cavernous sinus, you have to learn the anatomy from the lab. Then you apply your knowledge to your surgical routine.
Dr. Zhu, just a
Sanford,
moment.
sorry.
I think, we cannot
Was
see your
black.
slides right now. Sorry.
You cannot see the slide now?
No, we see only black screen.
So how to fix it?
Maybe it's because you selected another window. Maybe if you stop sharing and try again.
Okay.
So can you see now?
Yeah, now we see it.
Yes.
Yeah.
Okay, sorry. So for the surgery in and around the cavernous sinus, you have to start your work in the lab to learn the anatomy and practice the skill. Do as the same as in your surgeries. So based on my experience and what I learned from mentors, I started the cavernous sinus surgery from, I classified the learning curve of the cavernous sinus surgery into 4 levels. So for the beginners, I suggest to start the cavernous sinus from the superior wall, then move to the lateral wall and the posterior wall, and do the complex surgeries combined with the coarset approach. And as I said, you have to press your skill in the lab, so you can do the same steps. Is that the same as in your surgery? And based on the anatomy of the cavernous sinus, you have to learn some important landmarks. For example, you have to know the outer ring surrounding the carotids, the tentorium, and the anterior clinoid, posterior clinoid, petrous bone, and all the complex venous channels, and most of the important, the neurovascular structures. And as you can see, the black blocks, actually, it is the basics for the surgery in and around the cavernous sinus. It evolved from the Dorello approach. So the basic approach to the cavernous sinus, you have to know how to peel the dura off the lateral wall of the cavernous sinus to expose the anterior clinoid, and you have to know how to remove the anterior clinoid and remove the dura ring, so you can accomplish the basics of the microneurosurgery in the cavernous sinus. And based on these basics, you can modify the approach to different pathologies. For example, you can do a different kind of the approaches to different pathology in and around the cavernous sinus as shown in this slide. So as I said, I would like to suggest everyone to start the cavernous sinus surgery from level 1 to level 4. Level 1 corresponding to the superior wall of the cavernous sinus. If you know how to expose and open the superior wall, you have to remove the anterior clinoid and remove the ring so that you can open the corridor to the sella, suprasellar, interpeduncular fossa. So you can deal with the some pathology like ophthalmic aneurysm, tuberculous sellar meningioma, or some intraorbital tumor. If you gather your experience, then you can move to the level 2. So you know how to expose and open the lateral wall of cavernous sinus. In such situation that you are equipped with the technique, so you can deal with the complex paraclinal aneurysm, clinodal meningioma to achieve the symptom grade 1 resection, and some of the trigeminal schwannoma. Then you can move to the level 3. You have to open the posterior wall. In the posterior wall, there's 2 compartments, the oculomotor window and you have to divide the tentorium to expose the orifice to the macroscaphe, to the trigeminal nerve. So at the level 3, you are able to do the surgery for the base and the apex aneurysm and some complex dumbbell, like a dumbbell trigeminal schwannoma, and some invasive pituitary macroadenoma, and some ventral brainstem lesions. Then the most complex one is at level 4. At the level 4, you fully open the cavernous sinus and combine with the Kawase approach, so you can do the some large spatial clavicle meningioma, cavernous sinus meningioma, and chordoma, or some symptomatic intracavernous aneurysm. So I would like to emphasize some key concepts and techniques. As you can see, all the nerve and the vessels that penetrates the dura into the cavernous sinus, they form the ring-like structure surround these structures. So to do the cavernous sinus, you have to know how to free all these important neurovascular structure from the ring-like tissue, so that you can widen the window between these nerves or the vessels and minimize the traction on these nerves to minimize the injury. So the key concept is to unlocking the cavernous sinus, free the neurovascular structure from the rings at the beginning. So I would like to show some examples at different levels. For the level 1, as I said, you have to know how to expose and open the superior wall, so that you have to remove the anterior clinoid and remove the dorsal outer ring, so that you can deal with such a aneurysm like an ophthalmic aneurysm. For example, you remove the anterior clinoid, then you can resect the outer ring overlying the dome of the aneurysm. So when you fully expose the neck of the aneurysm, then you can put a clip. So usually the clip in the aneurysm is the most easier step of the whole procedure. And also another example is the tuberous sellar meningioma. You need to remove the anterior clinoid and cut the dura ring, and because it's very important to release, as I said, you have to release the nerve at the beginning of the surgery. For the tuberous sellar meningioma, you have to cut the phospholigament out the ring to free the optic nerve. So in this picture, as you can see, when I remove the anterior clinoid, I reset the outer ring, and you can see the ring, the optic nerve is pushed by the tumor against the phospholigament. So when you cut the phospholigament, you can see the indentation overlying the optic nerve. So this is very important. If you free the optic nerve, then you can widen the space. When you remove the tumor, you will minimize the traction on the optic nerve so that you can minimize the complications or the post-op of the blindness. Then if you got more experience, then you can do the level 2 surgeries. For example, you can do some complex paraclinal aneurysm or some large intracavernous aneurysm with symptoms. In this situation, now you have to widely expose the lateral wall of the cavernous sinus because you may need to open the windows, for example, to open the Parkinson triangle to get the proximal control. For such a case, as you can see, I fully expose the lateral wall of the cavernous sinus. Then I open the Parkinson triangle between the trochlear nerve and V1, so I can localize the intracavernous carotid. Now I can get the proximal control. So I got the proximal and distal control. Then I can trap the aneurysm. So I can easily shrink down the aneurysm by coagulation. So then you facilitate the flipping shaping of the aneurysm and preserve all the perforators from the carotid. So this is the after the surgery. As you can see, I clip the aneurysm, and because I can get the proximal and distal control at the beginning. And for some, a tumor like a periphery trigeminal schwannoma, if you know how to open the lateral wall of the cavernous sinus, then you know actually this kind of tumor actually is bulging from the macroscaphe. So it's very easy to remove the tumor when you fully expose the macroscaphe. But for some complex trigeminal schwannoma extending into the treponine or posterior fossa, then you not only to open the lateral wall of the cavernous sinus, but also you have to open the posterior wall of the cavernous sinus by dividing the tentorium. In these surgical photos, as you can see, I fully open the lateral wall of the cavernous sinus. Then I need to cut the dura at the base of temporal to expose the macroscaphe. Then I can open the macroscaphe and then divide the tentorium so I can follow the trigeminal nerve down to the SC zone from the brainstem. So as you can see, from the periphery of the trigeminal nerve to the SC zone, you can follow the whole course of the nerve. And also you can mobilize the trigeminal to localize the abductor nerve behind it. So in such a surgical approach, actually, you can deal with the different kinds of the trigeminal schwannoma using, if you know how to expose and open the lateral wall and the posterior wall of the cavernous sinus. So in such a case, you fully open the lateral wall of the cavernous sinus. As you can see, the tumor is bulging from the macroscaphe. When you open the macroscaphe, you can debulk the tumor, then you identify the branches of trigeminal nerve, like you did the other, for example, the acoustic neuroma or the lower cranial nerve schwannoma. It's the same techniques. Do the subcapsular dissection, and you follow the nerve to cut the tentorium, following the nerve down to the SC zone and remove the rest of the tumor. And you can preserve the branch of the trigeminal nerve. And also, the most encountered situation is the basilar apex aneurysm. And why I put the basilar apex aneurysm at the level 3? Because usually I need to open the posterior wall by opening the oculomotor windows to get, and also the posterior clinal process to get the proximal control. As you can see, I open the posterior wall by free the oculomotor nerve from this window. So I can mobilize the third nerve. Then I need to remove the posterior clinoid so I can get the basilar trunk. So I got the space to got access to the proximal control. Only you got the process control so that you have the confidence to deal with the aneurysm. Now I have proximal control and distal control on bilateral PCA, so the clipping the aneurysm become the easier steps of the whole procedure. Then sometimes, in some selected cases, if you have the invasive microadenoma, I believe that most of the people, they will refer the patient for endoscopic approach. But for me, actually, I think it's also another choice when you know how to open the cavernous sinus to remove each corner of the tumor from such kind of the invasive tumor. For example, in such a case, the tumor is invasive into the cavernous sinus, and this is pre-op, this is post-op. A similar case. So when I fully expose the cavernous sinus, usually you have to starting from the superior wall, lateral wall, and posterior wall. So at the beginning, actually, the clinoid is usually eroded by the tumor, so it's become very fragile and easily to remove. When you remove the clinoid, you expose the superior wall, you remove the tumor, so you can easily identify the clinoid portion of the carotid. So you can follow the carotid into the lateral wall, each windows. So you can open the window between the oculomotor nerve and trochlear nerve, and remove the tumor, following the carotid. Then you have to identify the abductor nerve. Then you can jump to other windows between the third and fourth and V1, the so-called Parkinson triangle. And so step by step, you remove the tumor in each corner and following the intracavernous carotid. Then you can remove the tumor in the suprasellar and sellar region. So you can remove the tumor and to expose the carotid, the pecon, and all the perforators, and also the pituitary stalk. So this is the post-op, the pictures when you remove the tumor in each corner. And at the level 4 is the most difficult one. You have to fully open the cavernous sinus combined with the anterior protrusal approach. For example, in such a case, is the VVJ junction large aneurysm. This is the post-op angiography. So in this case, I choose the transcavernous approach. For example, I fully expose and open the cavernous sinus. As you can see, you can see the carotid artery, the optic nerve, oculomotor nerve, trochlear nerve, and the trigeminal nerve. And I open the posterior fossa so I can localize the right side and left side VA. So the VB junction is below the fifth nerve. In this case, I got the right and left VA, so I got the proximal control. And I also can have the distal control in the base of the trunk. So as you can see, this is the aneurysm below the trochlear nerve and the fifth nerve. So now I got the proximal and distal control. So clipping the aneurysm become easier. So I got the proximal control. Then I had the distal control, so I can shrink down the aneurysm and put the clips for clip shaping of the aneurysm. So this is the post-op picture. So as you can see, this is a very good approach if you know how to fully open the cavernous sinus and also combine with the anterior trapezial approach. So you can expose almost the whole course of the basilar artery from the VA to the apex. And also the most typical one is the petroclival meningioma, like this one. It's similar to the invasive pituitary macroadenoma. I fully open the cavernous sinus, removing the anterior clinoid process. and skeletonize in the optic canal to then I prepare the exposure. So I do the Kawase anterior protracectomy, preserving the GSPN. Then I starting from the optic nerve. So I free the optic nerve from the phospholigament and I remove the tumor. Then I move to the oculomotor window to remove the tumor, free the oculomotor nerve. Then I free the tracheal nerve. Then I open the macroscope to free the trigeminal nerve branches. Then I remove the tumor within the cavernous sinus by opening each windows. And the most important is to localize the abductor nerve. This is abductor nerve. So everything, and you have to identify the groupal ligament because when you remove the tumor, everything outside the groupal ligament is safe because the abductor nerve is anterior to this ligament. So you can free the abductor nerve from the Dorello canal. And this is the post-op pictures. So we just published our experience for the learning curve for the cavernous sinus surgery in Journal Neurosurgery last year. And as Paulo mentioned, the evolution of the cavernous sinus is from, stay away from the cavernous sinus, and now the cavernous sinus surgery become possible. It's based on the surgeon's competency. So as Professor Yasok mentioned, the surgeon that complex elimination of the CNS lesion will carry the risk of the significant morbidity and mortality, neglects to consider the fact of the surgeon's competency. To improve the surgeon's competency is not, you have to, as I mentioned, you have to do a lot of work in the lab and apply your knowledge and techniques to your surgeries. So the content I presented today represents the level that I can achieve at present. But I believe that as long as I maintain my passion and faith, I will achieve greater accomplishments tomorrow or in the years to go. So it's my honor to host the 4th International Rhoton Society meeting in this November 5th to 7th. So you're welcome to Taipei. The venue of the Congress at the Grand Hyatt Hotel, and a lot of the distinguished speakers have accepted the invitation and they will join the meeting. And also we had a pre-meeting course. We have a fiber dissection and brain anatomy dissection course directed by Wayne and Carolinas, and also some distinguished faculties like Mustafa Baskaya. And also we had the skull-based hands-on course directed by Luis Bova and Mafti, and also Professor Kono, and they are all our distinguished faculties. And this meeting actually in tribute to my one of my great best friends, Professor Evandro, and we tried to do the hologram to have Professor Evandro to give a talk on the stage. We're using this technology. Now we are working on his voice by AI technology. So I hope we can make it, and everyone are welcome to listen to Professor Evandro's speech in Taipei. Thank you very much.
Congratulations, very nice talk. Fantastic cases you showed us. So can you just give us 2 or 3 tricks about how to achieve a good hemostasis during the exposure of the cavernous sinus, during the first step of the dissection, while you are opening it to the nerves? How much time you need to open fully, and give us some technical tricks if you can.
Actually, it's difficult to say how much time you takes you do the exposure of the Cavernous sinus, because I spent almost 2 years in the lab in the Iraq. Whenever I saw the surgery by Professor Marty and Dr. Christ, then went back to the lab. I did the same steps as what they did in the Cavernous sinus. So I remember when I back to my hospital in Taipei, I remember the first case is pecan aneurysm. I using the extradural approach. I removed the anterior clinoid, removing the ring, so I got the proximal control. Then I can easily to access to the lateral aspects of carotid. So it's very easy to see the pecan from anterior dome of the aneurysm. So I remember the first case, I opened the superior wall of Cavernous sinus. It takes only 30 minutes to fully expose the aneurysm, because all the steps, all the maneuver and is already on my mind. I watch a lot of surgery from my mentors, and also I practice in the lab. So even the first case when I did on my patients is only, I finished the pecan aneurysm by extradural approach within 2 hours. So I just did the same steps in the lab.
Thanks a lot.
Yeah.
I think we can go to the last presentation if everybody agrees. So we have Luigi Mauro, that is was a fellow in our lab in Neuromed. He did a great job with the dissection, and now he's finishing his work on. We are working a little bit on the Cavasi approach, trying to refine some aspect about different steps, and he's focusing a lot about the sixth nerve and the risk of damaging the sixth nerve directly with the approach, not only during the tumor removal. So he will show us just a few minutes of his presentation about his work. Please, Luigi, go ahead.
Hi to everyone. Thank you, Paolo, for the presentation. Just a moment, please.
Poi condividi, ecco qua. Adesso devo andare semplicemente il desktop, condividi. Apri il processore di sistema. Apri preferenze di sistema. Di mettere sul mio. Ce l'hai sulla venire USB. Vedi un po'. Non di mettere sul mio. Adesso ok. Adesso vai sulla presentazione, vale? E fai lancio la presentazione.
Okay. Can you see? Okay, I am ready. Hi to everyone. I am Luigi Mauro, and I talk about the sixth cranial nerve through the anterior transpetrosal view. The subtemporal transpetrosal approach in selective case is an useful approach to reach the petoclival area. It is considered one of the most challenging approach in skull-based surgery, and the complexity of this approach is related to the complex anatomy of the petrous bone and the many relevant structures to preserve, such as the cochlea, the semicircular canal, the petrous carotid, and the GSPN. And it is a time-consuming surgery, and it has a deep location. In our clinical experience, we reported 2 cases of 6 cranial nerve palsy related to this surgical approach. Why? Probably this structure have a landmark. So we have the arcuate eminence that is a landmark for the superior semicircular canal. And we can find the GSPN with the neurostimulation, and it is a landmark for the petrous carotid. And if we remove the superficial bone, we can have this beautiful view. It is an anatomical picture, and we can know where is the cochlea. The cochlea is anterior to the internal auditory canal, inferior to the geniculate ganglion, and posterior to the petrous, to the first genu of petrous carotid. So, but there isn't a landmark for to identify the 6 cranial nerve. So we had the idea to analyze the relationship between the anterior transpetrosal approach and the 6 cranial nerve in the lab. So the anterior transpetrosal approach was performed on 21 heads, a total of 35 sides. And we taken all these measurements, the distance between the reds of 6 cranial nerve and the inferior petrosal sinus, and the distance between the gasterian ganglion and the 6 cranial nerve before it passes below the Gruber's ligament, and the distance between gasterian ganglion and the superior margin of the Gruber's ligament, and the end, the length of interdural segment of 6 cranial nerve from the dural porus to the Gruber's ligament. This is the result. We can see that the distance between 6 cranial nerve and inferior petrosal sinus is in average 7.9 millimeter, and the range is 5 to 12 millimeters. Another important measurement is the interdural segment. We have seen that this segment has a very wide range from 3 millimeter to 16 millimeter. And here we have all the measurement about the interdural segment. In a lot of cases, we have a short interdural segment, but sometimes we can see that this segment is very long. So the anatomy, the 6 cranial nerve exit from the pontomedullary junction below the level of the inferior petrosal sinus and passes in the prepontine cister to reach the dural porus where it became interdural. And the direction of 6 cranial nerve is convergent to the inferior petrosal sinus at the level of the petrous apex, where the nerve becomes interdural and passes in the sphenopetroclival venous gulf, a confluence of superior petrosal sinus, inferior petrosal sinus, and basilar plexus that join the cavernous sinus. So in this study, we analyze 2 segments of 6 cranial nerve that are particularly related to the anterior transpetrosal approach, the cisternal segment and the interdural segment. The first one, this segment run below the inferior petrosal sinus, and there isn't a risk of damage during the approach. As we know, the inferior petrosal sinus is the inferior limit of anterior transpetrosal approach. So we can't to damage this portion of the nerve. Instead, the interdural segment run very close to the drilling area with higher risk to damage it in this portion. But the injuries is related to the injuries is probably related to worm by drilling the bone close to the nerve, and we need a lot of irrigation. A lot of irrigation is necessary in the approach. So how we have seen, the interdural segment has a very wide range from 3 to 16 millimeter. So the sixth canal nerve can pierce the dura farther or close to the petrous apex. So we can have a long interdural segment that it means more way near the periostal dural layer of petrous bone, and probably more risk to heat damage during the drill. And here we have some cases where the interdural segment, we have long interdural segment, and we can see the relationship and the closeness with the drilling area. This is another case. We have very long interdural segment. We can also see the closeness with the drilling area also in this case. Instead, the short interdural segment means lesser way between two dural layer and more root in the prepontine system, where the nerve is protected by the cerebrospinal fluid, which can dissipate the heat. Here we have some cases of short interdural segment. In this case, we have the nerve pierces the dura very close to the petrous apex, and also in this case, we have a short interdural segment, and also here we have the nerve pierces the dura very close to petrous apex, with lesser risk to damage it. So the conclusion, the risk of damage the sixth cranial nerve during the anterior transpetrosal approach can be related to the individual anatomical variation, and probably the long interdural segment has a higher risk of damaging because the nerve ran very close to the drilling area. And under the trigeminal ganglion, there is the most closeness to the sixth cranial nerve, with probably the higher risk to damage the nerve. So the next step is to calculate the distance of dural porus from the bony surface, and also distance of the dural porus from the V3. And if dural porus is posterior to V3 or anterior, or it is just below the V3. Thank you for the attention.
Okay. Okay, thank you, Luigi, for this presentation. Someone wants to do some comment about this? Kentaro, are you still awake? What time is that? Microphone.
Almost 4 o'clock.
Oh, so let's go to sleep.
Yeah. Thank you very much.
Pleasure to see you. So we can, I think we can finish, and we will meet next month with jugular foramen, I think. It's going to be the next topic. Sebastien will organize and give us the connections. Okay.
That's good.
So we close and we will stay in touch for the next meeting. Okay. For everybody, you will receive the invitation to the Zoom link for the next month webinar. Okay. Thanks for organizing this, and I'll see you next month. Bye.
Thank you very much.
You.
Bye bye.